This conference will now be recorded.
All right, so we're going to start with the trauma overview. A lot of these lectures is we're going back to the basics and fundamentals of emergency medical services. So we're really going to hone in within this trauma overview and talk about kinetic energy and then also the mechanism of injuries that we're going to see associated with specific injury sites. So when we're looking at the kinetics of trauma, we're looking at the mechanism of injury and the transfer of that energy based on that mechanism of injury. And then we're going to utilize our index of suspicion based on what we have found as far as what our trauma assessment should entail and what specific components we should be focusing on. So when we're looking at this, and again, with kinetic energy, everything's going to be transferred within a straight line until it actually meets a curve. So if we have an individual who has fallen from a substantial height, that energy is going to be transferred until it meets a bend. So if they fall feet first and then land on their feet and their knees are locked, that energy is actually going to be transferred up until their hips. So we're going to see more injuries associated with the hips. And that's why we see a lot of motor vehicle accidents with individuals and they have those lower extremity injuries because that lower portion of the motor vehicle is actually going to be transferred up into their ankles or their knees or even their hips, depending on whether that's locked or not. So when we're looking at the kinetic energy and formulating our index of suspicion on a motor vehicle accident such as this, we know that the right car, that blue sedan, the individuals in the two front seats, the driver's seat and the passenger seat, we're going to see injury impacts and that mechanism of injury really focusing in on the cervical spine. Now the individuals on the left car, the silver sedan, specifically we're going to see a higher injury likelihood for the individual who's driving because that impact is directly affecting them. And then also we can see a lot of injuries associated with the left-hand side of that patient and major concerns as far as aortic dissection, and then again, cervical spine and injuries to the thoracic cavity. When we're looking at gunshot wounds, again, we got to be thinking of what's inside the body in that pathway of that specific bullet. So if I see an entrance wound and I see an exit wound, I can kind of formulate what organs are going to be affected based on that pathway. Now, if I see an entrance wound, but I do not see an exit wound, then I really have to formulate all of the surrounding areas that could be affected because that bullet most likely is going to bounce around, it's going to tumble, it's going to affect a lot of different areas in comparison to looking at an entrance wound, an exit wound, and then I can formulate based on what organs are going to be affected from that pathway. With low velocity trauma kinetics, specifically penetrating injuries such as a knife, I'm majorly concerned about the depth and then the specific location of where that knife actually entered the patient's body. Falls, this kind of correlates to our motor vehicle accidents where oftentimes we're going to see multi-system trauma affected in comparison to our high velocity such as our bullets and or our low velocity such as our knives. Remember, falls is a high category for morbidity and mortality rates, specifically with our geriatric patients, because a lot of times the hips are affected. The hips pose a real issue because there's a large space that blood can collect, and then also very vasculature when it runs through there. So they can lose a potential of 3 liters of blood loss from a hip injury like that. And then blast injuries. And blast injuries we're going to talk about in much greater detail once we get to that segment within the PowerPoint. So when we are looking at kinetic energy, what we're looking at is mass and velocity. So the bigger the mass, the faster the velocity, we're going to see more kinetic energy. So remember too, with that velocity, even when we have a small mass, we can see a substantial transfer of that kinetic energy that's transferred from the incident to our patient. Because a good example, we got Colton Lorenz is stupid fast. and he's running at a pretty good clip, he's going to create a lot of kinetic energy when he is running at that velocity. But our specific formula is mass times velocity squared divided by 2. We don't really care about the formula. What we need to take out of this is a large object moving at a fast velocity is going to transfer a lot of kinetic energy to our patient. So with acceleration and deceleration, this is where we're tailoring in our mechanism of injury and then seeing what different types of injuries most likely that we're going to see. Because remember, we have Newton's law that's acting upon. So an individual who's traveling at 40 miles an hour within a car and they come to an abrupt stop, such as hitting another car, that individual is going to travel at 40 miles an hour until they are acted upon by an outside force. And then their organs are going to be traveling at 40 miles an hour until acted upon by an outside source. So multiple different impacts when we do see a substantial mechanism of injury. So we have acceleration injuries and deceleration injuries from that point of impact, and then the patient trying to go back to that normal status. With that organ impact, specifically with organs that are not heavily protected, we're going to see that acceleration and deceleration injury. Specifically, our brain is the major impact and major concern, as well as the cardiovascular system and the pulmonary system. So when we're looking at this individual was impacted from the rear in a motor vehicle, and we can see the brain is situated in the skull and it's surrounded by cerebral spinal fluid. So that brain is going to bounce back and forth within the skull. So we're going to see injury impact to the rear portion of the brain and then injury portion to the front of the brain. So the back portion of the brain basically controls all the animal instinct as far as our cerebellum goes and our brainstem. So it controls our heart rate, our respiratory rate, blood pressure. So when that's affected, we can see some of those goofy vital signs, such as our Cushing's triad. And then frontal impact, our frontal portion of our brain, that frontal lobe is actually in charge of personality and reasoning and social interaction. So we see a lot of times that altered mental status or somebody acting extremely goofy when that frontal portion of the brain is affected. So the impacts, again, we have that vehicle collision, we have body collision, and then we have organ collision. So the next few slides, we're really going to be focusing in on motor vehicle accidents, different impacts, and be thinking what different types of injuries that you're going to see associated with what side of the impact that actually occurs on. So when we're formulating our general impression and we are approaching our scene, we have to have a high index of suspicion that we're going to see a multi-system trauma or a critical patient when we see some of the following. So if there is a death within that vehicle, any type of altered mental status, if there is 12 inches of protrusion inside of the specific cab area and or 18 inches anywhere throughout the vehicle. Now, when this trauma research was correlated, they did not take into effect the newer style cars where we actually have a safety zone built in that car will crumple and create a cushion of safety. So that 18 inches isn't very prevalent in today's technology. What I'm more concerned about is that specific impact area and how much kinetic energy was actually transferred to my patients and looking at how much impact within the compartment area was actually in there. And then of course, if we have an individual who is actually ejected from the vehicle, that's going to be multi-system trauma. Any individual who's thrown from a vehicle, the morbidity and mortality statistics are extremely high. So let's go ahead and take a look at frontal impacts. We're going to see both an incident where somebody is not restrained and somebody who is restrained. So be looking at all of those different impact zones that this driver is actually going to experience upon this collision. As we can see, this particular driver is not restrained And then the model of this vehicle did not have an airbag deployment. So our big concerns here with the unrestrained driver obviously is going to be substantial thoracic injuries. We're going to have cervical spine injuries, and then also we're going to have a head injury because we did see splintering within that windshield. One thing that we do not focus enough on when we do have these motor vehicle accidents is lower extremity injuries and then also abdominal injuries. So that abdominal injury oftentimes is going to be associated with how that individual has actually worn that seatbelt. If it's above the hips, then that impact, that kinetic energy is going to be immediately transferred to the GI organs. And then we can see within these pictures, the knees and the hips being affected from that individual being propelled forward, and that energy is going to be transferred to the knees, the femurs, and the hips. So other injuries that we're going to see, and we're going to break down each body system. So within the abdomen, what we're looking at is different organs and how they actually function within the body. So with our solid organs, they're very vasculature, they hold a heavy amount of blood. If those injuries are correlated to that solid organ, what we could see is a lot of internal bleeding. Specifically when we're looking at the liver, which is located in the upper right quadrant and a little bit in the lower right quadrant, if that's affected, that's a very large organ and a lot of blood can actually protrude from that injury site. When we have our hollow organs, such as our GI system, like our stomach, our large intestine, and our small intestine, when those rupture, a lot of acid and a lot of toxins actually get released inside the body. So things that we may not notice immediately on scene, but that chronic and continuation of care, we're going to see sepsis and infection from that leaking site. And that's why it's so important that we are doing a good, thorough, rapid, and detailed trauma assessment to try and identify first immediate life threats and fix those immediate life threats, and then also formulate those secondary injuries that we may not be able to fix. But if we can relay that information further up the chain, this individual will get that care that they need at a quicker pace than if we don't find those injuries and that documentation and communication is lost in translation. Now, injuries to the cardiovascular system and within the chest, we could see tension pneumothorax, and that can be from most likely a penetrating injury inside the thoracic cavity, but a significant blow to the chest could also cause a simple pneumothorax, where we have a complete cavity closure of that chest cavity, and then eventually that could lead into a tension pneumothorax. Other injuries, specifically with the heart, we could see cardiac contusion, where we have bruising on the heart, and then that could also lead to pericardial tamponade. And so tamponade, we actually have fluid buildup around the lining of the heart, and it impedes that heart's ability to actually get preload and afterload when it is pumping blood to the rest of the body. Face, head, neck injuries, cervical spine is the one that's going to be most affected because that is the least protected portion of our spinal cord. And we can see within that frontal impact that that neck is swaying back and forth, and that neck can only go so far. So very important when we are doing our rapid and detailed trauma assessment to get the hands on the back of that patient's spinal cord, and we're looking for any decap BTLS and then any step off from that spinal cord as well. And then we're going to correlate that within our trauma assessment to identify CMS in all four extremities. Lung blowout, we don't see this very often anymore because almost every vehicle that we're going to encounter is going to have airbag deployment. But if we do have a collision, that airbag doesn't go off, that individual strike wheel, remember our lungs basically are balloons. So if they strike that steering wheel, there is a chance that that lung could collapse as far as blowout goes. Now with rear impact, very similar injuries that we're going to see is the frontal impact. So let's go ahead and take a look at this study. And this is only going 6 miles an hour. Now keep in mind this vehicle is relatively old, so they don't have that safety cushion built in. But the biggest thing, even with those low speed collisions, is the fact that that cervical spine is being thrown forward and backwards. And we can see some substantial injuries even from those low speed incidents. Again, our abdominal, our chest cavity injuries, our lower extremities, our facial injuries, oftentimes are going to be the same between our frontal impact and our rear impact. Lateral side impact all depends on which side of the vehicle was affected and what the specific position of that driver was. Now with lateral side impacts, especially at a substantial speed, so anything over 30 miles an hour, major concern is aortic dissection. The aorta, not very well protected, and when we have a substantial mechanism of injury with that transfer of energy, that aorta can shear away, and then as a result, that blood starts pouring out inside of the thoracic cavity, and it's not actually being distributed to the rest of the body to create that tissue perfusion. So if we arrive on scene, we have a substantial mechanism of injury as far as lateral side impact, that patient's in cardiac arrest and we're not really seeing a lot of other injuries, chances are that's probably going to be an aortic dissection. Other injuries that we're going to see, again, so going back to the law of inertia and Newton's laws, remember that individual will stay in motion until acted upon by an outside force. So when we got that seat belt on, we can see this individual will travel to a point where that seat belt will actually stop that patient. So we can see that right about there. The patient can no longer be moved forward, and that's where we're going to see that aortic dissection. This is where we're going to see a significant compromise to the cervical spine as well, and then any other tearing and or damage to any internal organs. So rotational and rollover crashes, very difficult to identify the specific kinetic energy that is actually going to be transferred to our patient. What we're going to consider these is multi-system trauma, especially if somebody is actually ejected from the vehicle. So again, honing in on your detailed and your rapid trauma assessment. When we're doing a rapid trauma assessment, that should take us about 30 seconds. What we're looking for is immediate life threats, such as compromise to the airway, the breathing, the circulation, and then also identifying any major bleeds and taking care of any of those. Detailed trauma assessment, we're going through to see if we missed anything, and then also look for those secondary injury sites. So this vehicle is traveling at about 45 miles an hour, unrestrained drivers, and we can see with that 45 miles an hour how far these individuals are actually ejected from that vehicle. Now again, survival with an ejected individual traveling greater than 40 miles an hour, morbidity and mortality rates are very high. What we can do as EMS providers, big thing, control our airway and our breathing, perform CPR as needed, and then identify those immediate life threats such as substantial bleeds. We're going to talk about bleeding quite a bit in our next lecture. So with vehicle versus pedestrian collisions, we got to keep in mind our mass times our velocity. So how big was the vehicle? How fast was the vehicle traveling? And then be looking at the center of gravity for our patients. And this is going to depend on whether that individual is going to get thrown on the hood and or whether they're going to be tucked underneath that car and then actually roll, depending on how high that hood is. And then with our age groups of our patients, when they are struck by a vehicle, as adults, we get trained over time to look away from danger. So oftentimes when an adult is struck by a vehicle and they have any time to react, they're going to go ahead and face away from that car. So we're going to see a lot of injuries to the back, the pelvis, the legs. Pediatrics are quite a bit different. They have not actually developed that educational material as far as facing away from danger. So they will actually face towards that danger. And we see a lot of injury impacts to the frontal portion of the body when we do have a pediatric that is struck by a vehicle. Now, as far as injuries go, again, it is going to be a multi-system trauma patient where we're going to do that detailed and that rapid trauma assessment. So these are dummies. Cars are traveling in between 45 and 50 miles an hour. So because they're dummies, the center of gravity is quite a bit different than a real patient. But just look and see how far that these dummies are actually thrown. So we can see it when somebody is actually situated on a bicycle too, their center of gravity is actually up higher than what it normally is. And that's where we see a lot of individuals get thrown up onto the windshield and then tossed. So injuries from restraints, when the patient is restrained, we are going to see some injuries associated with that, but if all of those restraints and all of those safety mechanisms are working together, they're going to be minor injuries. The biggest thing is lap belts, and they are not actually attached correctly so that the lap belt is going over the pelvis, but over the abdomen. So we can see with this patient, relatively large patient, that lap belt was actually situated over the abdomen and not over the pelvis at all. And so we're going to see substantial injuries from that kinetic energy being transferred from that impact, and then that individual either striking the lap belt and or the airbag deployment. But a lot of GI system and organs that are going to be affected here. We can see the shoulder belt going across. We're going to see some bruising there. Hopefully we don't have any broken ribs as far as the flailed chest segment goes. Remember, a flailed chest segment, we have paradoxical movement from multiple broken ribs in multiple different locations. Another example of that injury from that lap belt. And then when we have facial injuries from the airbag deployment, oftentimes it's abrasions and they're relatively limited. As far as car seats, with tether and without tether, we can see the injuries to that cervical spine when we do have a front and or a rear impact area. With motorcycle injuries, what we're looking at is we're looking at a smaller mass, but a high velocity most likely. And then also we don't have the safety mechanisms that are built in, such as somebody traveling in a sedan. Liter-and-a-half per femur fracture. Average adult only carries about 5 to 6 liters of blood, so we're looking at half of blood loss potential with an injury site like this. If that individual does not have a helmet on, the morbidity and mortality statistics are extremely high. It also correlates to whether that patient's got leathers on. So let's take a look at some of the impacts from a motorcycle accident. So when we're doing our trauma assessment, not only are we assessing our patient, but we are also inspecting that compact zone. So make sure that we are looking at that motorcycle to see what impact it was and what was affected. Now, as far as helmets go, when we have a significant traumatic event and we are assessing our patient, the patient's got a helmet on and it's close fitting, and we can go ahead and remove the face cage as far as addressing any airway management goes. We're going to keep that patient's helmet on. We're going to remove the face shield, and then we can go ahead and assess our patient. In the event that we have a substantial injury, that helmet is either ill-fitting and or we can't remove the face cage, we're going to remove that patient's helmet by trying to maintain C-spine to the best of our ability. Instead of taking C-spine from the back, we're going to take it from the front. So I'm going to put my hands underneath the jaw on the lower portion of the head, and then my partner is going to go ahead and take that helmet off from the top portion of the head. So falls, whenever there's a fall greater than 2 times the height, mortality statistics are extremely high because there's a high transfer of energy. And then also any fall more than 20 feet, the organs oftentimes have a significant deceleration and acceleration injury. So this is where we could see more of that aortic dissection from that mechanism of injury. We can see how falls actually plague the healthcare system, and then within those statistics, so 25,000 individuals die every year from simple falls, slips, trips, and that's why it's very important that even when we have that low impact as far as mechanism of injury goes, that we're doing that good, thorough trauma assessment. So low velocity, we touched a little bit on this earlier in the slide. Again, what we're looking for is the depth of that knife and then the specific impact zone and what organs or what vasculature was affected based on that impact zone. So as far as penetrating injuries, there's only 2 times that we actually remove that object. One, in the event that the patient is in cardiac arrest and we need to perform chest compressions and it is interfering. The other one, if it is embedded in the cheek and we can see both sides of that object once that patient opens their mouth and it is interfering with airway management, we can go ahead and remove that. Now, we arrive on scene, this patient's in cardiac arrest. We need to determine whether we are actually going to start CPR or not, because we have to be thinking about, is this injury unable to sustain life? Because this is going to be a crime scene. So if I actually determine that I'm going to perform resuscitative efforts and remove that knife, again, I'm going to be compromising that crime scene and that investigation. Always be cognizant, whether it's on the front or the back when we have penetrating injuries like this, A, bleeding control, and then B, trying to minimize the atmosphere actually getting inside that thoracic cavity and creating a tension pneumothorax. So with tension pneumothorax, some of our signs and symptoms that we're going to see: shortness of breath, could see cyanosis, and the big one is listening to lung sounds. So if we hear absent or diminished breath sounds on one affected area or side, that is an indication of tension pneumothorax. So if we can identify that and then communicate that with Mayo, they can perform that needle decompression sooner rather than later. When we should be auscultating lung sounds for our traumatic patients should be done immediately after we get done inspecting and palpating the chest during our rapid trauma assessment. So our medium and high velocity injuries, these are going to be correlated to our gunshots. So remember, entrance wound, exit wound, we can identify both of those injury sites in that pathway. Make sure that if it is within that thoracic cavity that we are providing an inclusive dressing on both the entrance wound and the exit wound. That bullet is going to provide cavitation through the tissues, so we're going to see a lot of injuries associated with that. And then it depends on how far away that individual was when they did get shot, and then the specific caliber and the firearm that was utilized is going to be dependent upon the cavitation and the internal impact from that specific bullet. Here we can see that cavitation again once it enters the zone, and it creates that wave, and then it really destroys and impacts that tissue while it is going through that patient's body cavity. So gunshot wound injuries, specifically when we have an injury to the head, if it is impacting the back portion of the head, this is where we're going to see that patient in cardiac arrest. If it enters the frontal portion of the brain, this is where it's going to impact the frontal lobe, where that individual still has the brainstem and the cerebellum intact, so they're most likely still breathing and or have a good pulse, but they may be unresponsive at that point. Chest injuries, depending on where that bullet went in, we could see tension in the thorax, we could see severe bleeding depending on whether it hit a major blood vessel. Abdomen, solid organs, hollow organs, we're either going to see substantial bleeding and or we're going to see distension and swelling from the gastric intestine toxins and fluid that's actually being depleted into the system. With blast injuries, there's going to be three different phases. We have the primary phase, which is from the initial blast wave zone. Secondary phase is going to be from flying debris. And the tertiary phase is that individual being thrown and they either hit the ground and or hit some other immovable object, such as a building. So different injuries that we're going to see with that primary blast, that waveform really affects all of our hollow organs. So we could have lung collapse, we could have injuries to the GI system, secondary injuries, that flying debris, rocks, stones, what have you. We could have injuries to the musculoskeletal system, and we could also have penetrating injuries. And then, of course, once they land on the ground, that's going to be more musculoskeletal system trauma. Multi-system trauma, this is going to be where we have more than one body system that's going to be affected. Again, we touched in pretty good detail on this, so make sure that you are doing a good, thorough trauma assessment on your patient. Now, with trauma, what we have is a golden period. From the specific time of the instance, we have about 60 minutes to try and get that patient treated as far as immediate life threats, transported into the ER within 60 minutes. That gives us the highest success rate for survival for that patient. When we exceed that golden period, exceed that golden hour, our success rate dramatically drops. And this is correlated to our platinum 10 minutes, where we need to maintain or try and maintain 10 minutes of on-scene time before transport. And obviously, this is kind of out of our control because we are dependent upon Mayo Clinic for that transport. However, we as EMS providers oftentimes getting on scene before Mayo does, if we can address those immediate life threats, get that patient packaged and ready for transport, so when Mayo does arrive on scene, we're ready to go, get that backboard up onto the stretcher into the ambulance, and then we can immediately start transporting. Within the trauma system itself, we have level 1, we have level 2, we have level 3 within our service area. So Essentia Health is going to be our level 1 trauma system. Level 2 is going to be St. Luke's. Level 3, kind of level 2, is going to be St. Mary's Superior. They do have some capabilities. Any significant mechanism of injury, always try and recommend these individuals go to Duluth. Specifically, if your family is on the fence as far as where to send the loved one, try and recommend Essentia Health because again, that is going to be our level 1 trauma center. Special considerations we got to be thinking of when we do have a substantial injury or substantial trauma patient. Scene safety, we all know the data and statistics behind firefighters, law enforcement officers, EMS providers being struck by a vehicle when we are working on that road scene. So try and block off that roadway. Aggressive airway management, utilizing suction when we do have copious amounts of blood and secretions inside the airway. Stopping significant bleeding, and then making sure that we utilize rapid transport. And don't forget, we can always use that backboard as a full body splint, so we're not screwing around trying to splint secondary injuries. All right, so I've been talking for about 45 minutes. Let's take a 10-minute break. We'll meet back at 9:55.
This conference will now be recorded.
So before we dive into bleeding and shock, does anybody have any questions in regards to anything that we covered thus far? All right, so let's dive into bleeding and shock, and then we're going to be looking at pathophysiology and the different types of shock as well. So our objectives for this, we're going to be going over key terms, different types of shock, specifically blood loss, hypoperfusion, and then what we're going to see with our patients when they do deteriorate associated with vital signs, signs, and symptoms. So when we're looking at shock and or hypoperfusion, we're looking at inadequate tissue perfusion. So how we perfuse properly is we bring oxygen into the system. It is transferred via hemoglobin to all the different tissues of the body. With that presence of oxygen, what we need to do is create energy. So we create energy through metabolism by bringing oxygen in. As a result of that oxygen, we create an abundance of ATP, but then we also create a small waste material, which most of it is carbon dioxide. And then we go ahead and pick up that carbon dioxide with our hemoglobin, bring it back to our respiratory system, and then we exhale. So this is going to be referred to as aerobic metabolism. With the presence of oxygen, I'm creating a lot of energy and a little bit of waste material. When somebody goes into shock and they're not perfusing properly, we don't have the oxygen content and or the transport of that hemoglobin to all the different tissues of the body. Now the tissues itself, they still want to try and create energy and they still want to create metabolism, but it's going to be in the form of anaerobic metabolism, which is without the presence of oxygen. So we're still creating a small amount of ATP in the form of energy. However, we are creating a ton of waste material. That waste material is going to be a lot of lactic acid and then also carbon dioxide. And then it's very difficult for us to actually get that waste material outside of the system. So what we need in order to perfuse properly is we need an adequate volume, we need adequate pump function, we need adequate vessel tone, and these three things need to be working synergistically with each other and making sure that there's not an obstruction within those three communicating with each other. So our different categories of shock: hypovolemic shock, where we have low volume. So this could either be from whole blood content and or plasma content. Whole blood content, such as internally or externally bleeding. Plasma content, somebody's severely dehydrated, they're ill, vomiting, diarrhea, not eating properly. We can deplete so much fluid in the tank to the point that they actually go into hypovolemic shock. Another one, burn. So with burns, think of what our skin does, and it maintains body heat and it maintains water balance. So if we have a substantial burn that covers a large surface area, we are losing the ability to maintain body temperature. So we see that patient perhaps go into hypothermia. They're going to go into hypovolemic shock because they're losing that fluid balance. And then also we are eliminating the first line of defense against infection. So a lot of times these patients will eventually become septic because all of that bacteria and those pathogens enter inside the body. Next, with distributive shock, so this is going to specifically affect the vessel tone that makes perfusion proper. And so with septic shock, we have a massive infection that affects the entire body. And as a result of that infection, the cell permeability loses and we start to see our cells basically expand and explode. And then that's going to interfere with our vessel tone as well. We're going to have massive vasodilation, so that blood pressure is really going to go down significantly. Very similar when we have anaphylactic shock, we have an introduction of that allergen into the system, or B mass specialized cells identify that, and then they drop all the histamines throughout the body. When those histamines are released, what it causes is massive vasodilation. And so we're going to see that vessel tone get extremely dilated, and then again, that blood pressure is going to drop. Neurogenic shock has to do with the central impulses in the spinal cord being able to actually send messages from the brain to the rest of the body as far as shunting blood, constricting blood vessels, and or dilating blood vessels. So if I have an injury to my spinal cord, everything below my belly button, that impulse is not able to actually send. And I'm using the belly button as an example as far as where that injury site was located. So if I come across my patient and they're in neurogenic shock and I'm seeing pink, warm, dry skin everywhere below the injury site, and then above that injury site, that patient is pale, cool, diaphoretic, there's a disruption in the impulse from the spinal cord traveling down the pathways. So my body is able to relay that message to my upper extremities saying, shunt that blood, get that blood to the most important vitals and organs such as my heart, my lungs, and my brain, but I'm not able to send that impulse to my lower extremities, in which I still have that pink, warm, dry skin. Cardiogenic shock. So we see a patient in cardiac arrest from VTAC, VFib. The pump function is no longer working properly. Could also see that with myocardial infarction and then congestive heart failure as well. So obstructive shock, we may have proper pump volume, we may have proper pump function, and then we may have proper vessel tone, but something's going to interfere with those three things actually working together. So we could see this with a tension pneumothorax, where we have that pressure buildup so much that it actually collapses and pushes everything over to one side. We could see it with a pericardial tamponade with that fluid buildup around the heart, and also our embolisms. And then with metabolic and respiratory shock, metabolic, I talked about, that increase within waste material as a result of not being able to actually get that waste material out. We could actually have patients go acidotic, so metabolic acidosis from this waste material that's building up. And then respiratory shock most often has to deal with carbon monoxide poisoning. Major flaw in the system that our hemoglobin will bind to carbon monoxide 237 more times readily than an oxygen molecule. And then as a result of that, the patient's going to suffocate from the inside out. So now the next several slides, we're going to specifically focus on hypovolemic shock as it results to blood loss. So first, when we're looking at our normal adult, the normal way that patient perfuses and their normal vital signs, the average adult has about 5 to 6 liters of blood inside their system, and this is about 1/11 of the patient's body weight. So a 160-pound male patient is going to have about 5 liters of blood. Obviously, we know based on our demographics within our service area that most male patients are actually exceeding that 160-pound mark. But the normal vital signs that we're going to see if we have proper pump function, proper vessel tone, and then that proper volume, we're going to have a heart rate in between 60 to 100. respiratory rate 12 to 20, and then blood pressure of 120/80. Now, obviously, different medical diagnosis is going to interfere with those normal vitals. So just take into account that patient's body weight. When we have 1/11 of the patient's body weight, and we have Andre the Giant, who weighed 520 pounds, they had about 17.5 liters of blood circulating through his system. So when we arrive on scene and we have a large patient, chances are they're going to have a little bit more blood volume circulating through their system. If we come across grandma who weighs 95 pounds, they're going to have a little bit less blood volume than our 160 pound or 180 pound patient. So the patient's bleeding and they start losing a substantial amount of blood volume at about 15% of their value, which is about 750 milliliters for a 160 pound patient. So within compensated shock, the body is still able to perfuse properly. So we're still getting that blood to the tissues. We're still creating energy with aerobic metabolism, but we have to shift a little bit in order to compensate for that blood loss. And as a result, taking vitals, see an increase in respiratory, an increase in rate, and often the thing to go is going to be our skin condition. So when we see pale and cool, and body is actually shunting the blood away from the skin or non-vital organs to the most vital organs, our heart, our lungs, and our brain. If that patient continues to deteriorate, we're going to start to see some of those other vital signs, such as restlessness, maybe starting to show signs of an altered mental status. So if we're not able to control that bleed and that patient continues to deteriorate, they're going to go into decompensated shock. Within decompensated shock, the patient no longer is perfusing properly, so they have now switched from aerobic metabolism to anaerobic metabolism. Their tissues are not getting the oxygen that they need. They're not creating the energy in order to sustain life. And then we are also creating a lot of lactic acid and carbon dioxide that's going to build up within the system. So roughly 15 to 30% of blood loss is going to put us within that decompensated shock phase. And our signs and symptoms are going to be somewhat similar to our compensated, with the increased heart rate, increased respiratory rate. But we're going to see drastic changes to the mental status, decrease in body temperature, and then the big significant finding between compensated shock to decompensated shock is that drop in that blood pressure. So if that patient is hypotensive, then they are in decompensated shock at that point. If we are not able to fix the problem and that patient continues to bleed out, irreversible shock is anything greater than 30%. And this is where we start to see our vital signs drop to zero, and that patient is going to go into cardiac arrest. Now, unless that patient's sitting on an OR table, once they enter the realm of irreversible shock, the chance of survival is very unlikely. So now we're going to look at a couple of different injury sites and the potential of blood loss. Now, this doesn't mean that you break your femur and you immediately lose 1.5 liters of blood volume, but again, it is potential. So we got to be thinking of what major blood vessels are going through the specific portions of the body, how big that bone is, and how much cavity or space area that there is that blood can actually pool and collect. So when we're looking at an injury site like this is going to be a broken femur. A broken femur, potential blood loss is about 1.5 liters. Significant because that would put us within that 30% mark as far as decompensated to irreversible shock. And remember what I mentioned within the last PowerPoint segment was that a lot of patients will have bilateral femur fractures from those motorcycle accidents, ATV accidents, snowmobile accidents. So now that potential blood volume loss is actually 3 liters. So as far as treatments go for an injury site like this, first I want to control the bleed to the best of my ability. So for an injury like this, if they have actually severed that artery, we're going to see profusing bleeding. I'm going to immediately go to a tourniquet. Remember, with traction splints, There's this very specific criteria in order to utilize that. It's got to be a mid-shaft femur fracture. It has to be closed. There can't be any injuries to the pelvis and or the ankle. So with an injury site like this, because it is open, that's an automatic contraindication for utilizing that traction splint. When that injury site is closed and we're trying to identify whether it is indeed a femur fracture, be looking at the thigh itself because it's going to be bunched up, and oftentimes that affected leg is going to be a little bit shorter than the unaffected leg. Broken pelvis. So again, we have major vasculature that runs through there, very similar to our femur. And then we also have a lot of space cavity where that blood can collect. So with a significant pelvic injury, if those blood vessels are disrupted, there is a potential blood loss of about 3 liters of blood. And this is why that mortality rate is so high with our geriatric population and those hip injuries. So as far as treatments go, immediate identification that it is a hip injury, try and splint that in place, and then rapid transport of that patient. So now with an injury like this, we're dealing with smaller blood vessels, smaller space cavity, and a smaller bone. So this is a humerus fracture, and we're looking at about 800 milliliters of blood loss potential with something like this. But even at 800 milliliters, remember, that's going to put us right on the cusp in between compensated and decompensated shock. So as far as treatment plans for this, make sure that we're doing a good job as far as assessment of that CMS, make sure that we're getting blood flow to the distal portion of that extremity. You do have one attempt to realign that injury site in the event that you have poor perfusion or poor CMS to try and get that blood flow to the distal portion of that site. Once you do have good blood flow, go ahead and splint in that position of comfort. Provide pain management as far as ice packs. So similar to our humerus, we have a tib-fib fracture. Okay, smaller blood volume, smaller blood vessels, smaller space cavity, about 500 milliliters of blood loss. So that doesn't quite put us at that compensated shock value. I'm more concerned with an injury site like this to maintain perfusion so that this individual does not lose their left foot. So with that, I do my quick trauma assessment as far as identifying if there's any other immediate life threats. And then I'm going to focus in because most likely this is going to be an isolated injury. And I'm going to try and realign that this individual can have a pedal pulse, be able to wiggle their toes when I am doing that patient marking. So again, you have one ankle, so it's midline. Hopefully we start getting perfusion again, and then we can go ahead and splint. When we have a major artery that is exposed and then severed, we can lose all of the circulating blood volume within minutes. So if we identify this, we come across an injury site like this, don't screw around with direct pressure. Immediately go to your tourniquet, go high enough that you secure that tourniquet against the upper bone, so either the humerus or the femur, and leave just enough space so that you can apply a second tourniquet in the event that you need it. With thoracic injuries, penetrating thoracic injuries, if they disrupt that blood volume and those vessel tone, then we can be looking at, again, up to 3 liters of blood loss, very similar to our pelvic injury. So what we're concerned here with an injury site like this is controlling the bleed, trying to ensure that we're not getting air inside that thoracic cavity to develop a tension pneumothorax, and then trying to figure out a treatment plan as far as securing that rebar so that we can actually transport that patient. So some special considerations that we got to be thinking of are patients who take blood thinners, pregnant patients, peds, and infants. So with blood thinners, we have two different types. We have anticoagulants and we have antiplatelets. What anticoagulants do is it delays the body's reaction to actually creating that clot. Antiplatelets are going to create the platelets more slippery so they don't actually group together in order to create that clot. Now, there's a lot of different blood thinners out there, so when you are doing your sample history and patient assessment, make sure that any patient that has had a traumatic incident that we are asking them if they take any blood thinners. Now, the most common ones that we're going to come across as far as anticoagulants are going to be Coumadin, warfarin, and heparin. As far as antiplatelets go, aspirin and Plavix are the two most common antiplatelet that we come across. Again, make sure that you are asking your patient if they do take a blood thinner. If somebody takes aspirin and it's a low dose daily aspirin, it doesn't affect it all that much. Higher dose aspirin will affect their levels as far as trying to create that clot with that platelet effect. So with pregnant patients, we have to keep this in mind that they are going to increase their blood volume specifically within that second and third trimester in order to compensate for the growing fetus inside of them. So they're actually going to have an extra liter to 1.5 liters of blood. As a result of this, if there's a significant event, whether they're bleeding internally or externally, is that they could lose about 1,000 milliliters of blood volume without showing any significant signs or symptoms of that. Very similar to our peds and our infants is pregnant patients will compensate for a good period of time, but then they drastically decrease. And we always have to keep in mind how this individual is going to react in the event that they start compensating and decompensating. So when we're compensating and decompensating, I'm shunting the blood away from the non-vital organs to my vital organs. Mom, with that animal instinct and the animal brain, is actually going to begin to shunt the blood away from the fetus in order to protect herself. So if we have a pregnant female patient who's in compensated shock, chances are that fetus is actually going to be in a decompensated shock phase. So when we're looking at peds and infants, obviously we have a smaller weight-based formula for our blood volume. So if we have a 70-pound child, they only have about 2.5 liters of blood circulating through their system. Because of that, their normal vitals are a little bit different than the adult patient. They're dealing with a smaller blood volume, so in order to compensate for that, they have an increase in heart rate and an increase in respiratory rate. Now, they do have a lower blood pressure than the adult, and it's because the peds and the infants have not developed that systemic vascular resistance that we have as an adult, and that's why their blood pressure is lower. So as far as trying to figure out what a normal blood pressure is for our peds and our infants, this is the formula that you want to use. It's going to be, for normal blood pressure, should be 90 plus 2 times the age, and that is going to give you a systolic value. So if this individual is 7 years old and I'm checking their blood pressure, hopefully it is 90 plus 2 times 7, so that is going to be 104. I should be getting a systolic blood pressure of 104. For identifying patients who are hypotensive, it's going to be 70 plus 2 times the age. So if I take their blood pressure and it's systolically 84, then I know that that patient is hypotensive at this point. So when that pediatric patient starts losing blood volume, it only takes about 382 milliliters of blood loss to go into that compensated shock phase, 382 to 765 to put them in the decompensated, and then anything over 765 milliliters of blood loss is going to put them on the edge of that irreversible shock. Now with infants, they have a very small amount of blood volume that's circulating through their system. So if we have a 15-pound infant, they only have a little over 1/2 liter of blood that's circulating through their system. And again, that's why we see that heart rate and that respiratory rate so fast in order to compensate for that low volume. And this is a good recommendation and reminder too, as far as our American Heart Association guidelines, that if we have an infant and or a small pediatric that their heart rate is less than 60, we immediately start performing chest compressions and going through our CPR sequence, because with them being sinus bradycardia like that, they are not perfusing properly. Compensated shock for that 15-pound infant, only about 87 milliliters. 15 to 30% is 87 to 175. and then anything greater than 30% is 175 milliliters, which will put that patient into irreversible shock. So remember our different techniques as far as controlling the bleed. We have the different direct pressure that we can utilize. We have tourniquets, and then don't forget we do have quick clot within our protocols, which are going to create that synthetic clot. Remember to utilize your good wound packing techniques for something like this. Identify that specific portion where that bleeding is coming from, and then start to pack that quick clot directly on that injury site. So let's go ahead and review quick clot because I know that we haven't utilized it all that much.
What you're about to see is an excerpt of testing performed by the United States military to simulate the most severe battlefield injury imaginable, the complete bisection of the femoral artery and vein. The objective was to identify the field treatment that provides soldiers the best chance for survival. The following procedure was performed to test and compare the efficacy of currently available battlefield-appropriate hemostatic agents. Using subjects weighing approximately 110 pounds each, the trauma doctor slices through the soft tissue and all muscles throughout the vital groin area, down to the femoral artery and vein. The doctor now places his gloved hand over the wound to prevent the spurting of blood that occurs as he completely bisects the femoral artery and vein. The wound cavity is immediately flooded with blood. Suction is performed to measure the volume of blood loss as a hemorrhage is allowed to proceed uncontrolled to simulate the standard response time. If no action is taken, the subject will die due to exsanguation or bleed out, the leading cause of battlefield deaths. Using a wiping motion, the doctor uses gauze to remove excess blood and liquid from the wound. A single dose of quick clot, 3.5 ounces, is dumped directly onto the bleeding wound, and pressure is applied using the standard military dressing. Hemostasis is achieved almost immediately after applying quick clot to the trauma. After the gauze is removed from the wound, you can clearly see the quick clot. The top layer is untouched by the bleeding that normally would have saturated the pressure bandage. You can see quick clot is easily irrigated out of the wound, leaving behind a tenacious clot, resulting from its rapid absorption of fluids. This allows the body's own natural clotting factors to become highly concentrated. The treatments tested included the standard military pressure dressing, Marine Polymers RDH bandage, Metaphor's Traumadex, and Z-Medica's Quick Clot. Quick Clot was the only treatment that reduced blood loss and increased survivability better than the standard military bandage. In fact, Quick Clot was the only treatment to achieve a 0 mortality rate, or 100% survivability.
So the biggest thing with quick clot again is identifying specifically where that injury site is, and then packing that wound appropriately. Remember with quick clot, our way that we handle that bleeding differs a little bit than direct pressure. So if I'm providing direct pressure and my gauze pad gets saturated with blood, I'm going to go ahead and put another clean gauze pad on top of that. If I pack that wound with quick clot and it continues to bleed and it bleeds through my quick clot, I'm going to remove that and then start over with a fresh quick clot. So before we start on start triage, any questions thus far? All right, so let's start with start triage. So our objectives that we're going to be talking about utilizing this is how we are going to perform, how are we going to perform as EMS providers in the event of a mass casualty incident, utilizing different leadership roles and specifically honing in on that initial triage of our patients in order to get them to the treatment area and give them specific treatments, load them, and transport them. So with start triage, it's a very simple formula, simple triage and rapid treatment. And this is going to be utilized in the event that we have a mass casualty incident, in which a mass casualty incident is classified 2 or more patients that is going to deplete the available resources that you have readily available. Now, where the start triage algorithm was developed was the Newport Beach Fire Department in the 80s, and then it took off from there. The goal of this, very simple step-by-step approach that we are triaging and treating our patients with about 30 seconds or less, and then we are moving on to our next patient. Now again, this is the initial triage and treatment of our patients. So how this then formulated is developing a proper treatment area and then a proper transport area so that I initially triage my patients. I move them from that point of contact to my treatment area. I got my transport zone set up. I can provide treatments within that treatment area and get my critical patients transported, my yellow patients transported, and chances are I'm probably going to be calling a school bus or some other means of transport to get my green patients, and I'm probably going to transport those individuals to Moose Lake or farther outlying hospital so it's not interfering at St. Luke's or St. Mary's. When we are triaging our patients, every patient gets a triage tag. So the bottom color is going to designate which triage level that patient is at. So we have a very simple approach. We have 30 seconds or less to initially triage our patient and provide one of 3 or 4 different treatments. The treatments that we're going to provide when we are the triage officer upon initial triage is either I'm going to control an extremity bleed with a tourniquet, I'm going to open up the patient's airway in the event that they are not breathing, I'm going to provide a occlusive dressing in the event that they have a penetrating thoracic injury, and then some services are also utilizing quick clot within that algorithm so that if I have a abdominal or a chest injury, some bleeding site where I can't control it with the tourniquet, I'm going to go ahead and wound pack that with quick clot. So the triage tag itself, again, every patient gets it. We can see that there is a lot of different material on here that we can actually document for our patient. If I'm the triage officer, I'm not concerned about that. The only concern I have is tearing off the proper designation and then giving it to my patient or hanging it on my patient. So remember, bottom color is going to designate where that patient actually fits within the triage algorithm. Once this individual gets to the treatment area, if we have enough resources, then we can have that treatment officer or that transport officer actually fill out that triage tag so that it gets sent with our patient to the hospital so that that hospital staff kind of has those vitals and those assessment trends within that system. If you are the transport officer, which most of the time will be housed by a member from Mayo Clinic Ambulance, you see that there is tear off tags on the top. So you see the number 678406. I'm going to tear that triangle portion off. I'm going to put it in my St. Luke's pile, and I know that patient 678406 got transported to St. Luke's. The rest of the tag gets sent with the patient for hospital review. So where do we start? First, we're going to conduct our scene size up. So whatever captain is arriving on scene, or if it's the battalion chief, you're going to go ahead and conduct that scene size up, establish command, ensure that it is safe for your responders and or working within that warm area. Try and determine how many patients that you do have, and so that you can relay that to the hospital and then also call in mutual aid, because we want to call mutual aid sooner rather than later. With mass casualty incidents, not only in our area, but throughout the country, the one resource that we're going to be drastically limited at is the amount of ambulances that we can utilize. As far as scene safety measures, remember when we have bombs, detonation, terroristic events, then a lot of times they have secondary devices set up specifically to harm first response and EMS providers. So, well, I'm back working on Superior Fire Department, and I am captain at station. A call comes out for a mass casualty incident. I arrive on scene, establish command. Zimmerman arrives. We go ahead and provide the transfer of command to Bob. Now, Bob designates me as the triage officer. So the first thing that I want to do is I want to get all of the walking wounded out of the way. So I'm going to announce to the group, whoever's injured and who can walk, go to this area. Keep in mind where your treatment area is going to be located so that you're not separating these individuals too far away from where your treatment area is going to be. And then I'm going to announce anybody who is not injured, go to this area. And I'm going to keep these individuals relatively close because I may be able to use them as resources as far as transferring those patients from the point where they're hurt to the treatment area. Every patient who is injured and who can walk is going to go ahead and be handed a triage tag with the yellow tag on the bottom, signifying that they are walking wounded. Next, we are going to start at the closest patient. And so now we're going to differentiate our yellow, our red, and our deceased patients. Again, we have 30 seconds or less. So I'm going to start with my closest patient. Oftentimes the initial triage team is going to be composed of 2 individuals. So I'm the triage leader, and then I have another individual from station 2. So I'm going to be in charge of communication, radioing back into incident command or my extrication team, what type of patient that I have, where they're located, so that we can get that extract team in. So I'm going to take 30 seconds or less. I'm going to assess my patient, and I'm going to provide those minimal interventions and treatments that I have within my toolbox, and then I'm going to move on to my next patient. Very difficult or very easy to get overwhelmed in an incident like this, where we're looking at all of these patients. Try and focus on that one specific patient at a time. When you are that triage officer, you have 30 seconds with that patient, and then you're going to move on. Now, by no means do I say put on blinders, because remember, scene safety considerations are such a high priority in this. So keep your head on a swivel for scene safety characteristics, but focus your attention on one patient at a time. Now, what we're assessing when we are differentiating between yellow, red, and deceased is RPMs. And RPM stands for respiration, perfusion, and mental status. Those are the 3 things that we're going to check in order to delineate what color code that patient is. So I come across my first patient, and I'm going to check respirations. First, I'm going to identify whether that patient is breathing or not breathing. If that patient is not breathing, I'm going to open up the patient's airway utilizing a head tilt chin lift or a jaw thrust maneuver. Now, if that patient starts breathing on their own, or if they were spontaneously breathing on their own, then I'm going to go ahead and assess the respiratory rate. Any respiratory rate that's greater than 30, they are going to be tagged as red and or critical, and then I'm going to move on to my next patient. If their respiratory rate is less than 30, I'm going to move on to perfusion. If I open up that patient's airway and they are still not breathing, they're going to be tagged as black and or deceased, and then I'm going to move on to my next patient. Remember, our deceased patients, we do not move them at all. We leave them as they lie, because again, this most likely is going to be a crime scene investigation. We also don't want to waste our resources, especially the limited resources that we have, worrying about deceased patients. So I came across my first patient. They are breathing spontaneously on their own at 24 times per minute. So I'm going to go ahead and move on to perfusion. So perfusion, What we're checking for is a distal pulse or the absence of a distal pulse. Now, the START triage algorithm does talk about capillary refill time. This was, remember, developed in Florida, where they have nice warm days continuously throughout the year. If I'm checking capillary refill on a patient like today where the temperature is low, that capillary refill time is not a good indication of perfusion. Instead, I'm checking for distal pulses. So how that relates to the pathophysiology of the body, if I'm feeling a distal pulse, chances are that systolic blood pressure is greater than 90. If I'm feeling a carotid pulse and I'm not feeling a distal pulse, chances are that systolic blood pressure is greater than 60. So if I feel an absent distal pulse, I'm going to take this patient as red and or critical, and then I'm going to move on to my next patient. If they do have a distal pulse, I'm going to move on to my mental status. Now with mental status, if they are altered at all, then they're going to be classified as critical and or red. If the patient is alert and oriented, they're going to be classified as yellow. Because remember, at this point, we have determined that this patient cannot move themselves, so they wouldn't be tagged as green. This is the algorithm that we're going to utilize. Very easy. Again, assessment, respirations, perfusion, mental status, respiratory rate, distal pulse, and whether that patient is alert and oriented or not. So we're dispatched, active shooter event. We have multiple victims. Law enforcement secures the scene. Zimmerman has maintained incident command, and then he tasked me with being the triage officer. So I enter in, I'm in the warm zone, and I'm being supported by law enforcement at this point. So it's me and my partner. I come across my first patient. I have a 26-year-old male patient. At this point, I know that it's either going to be yellow, red, or deceased because I have already announced to the group, anybody who can move, get out and go to this location. Respirations are 24, so they are breathing. I'm going to move on to perfusion. I do have a distal pulse. He is alert and oriented. I identify a significant injury as far as a gunshot wound to the back. I could not find a picture of an individual with a gunshot wound to the back. So respirations are good, perfusion's good, mental status is good. I'm going to go ahead and take this patient as delayed and or yellow, and then I'm going to provide an occlusive dressing to that gunshot wound onto the back, and then I'm going to move on to my next patient. I come across my second patient after I've radioed in as far as the location of the first patient. 65-year-old female, gunshot wound to the chest, respirations are 36, absent radial pulse, alert and oriented. Now I could have stopped my assessment here because my respirations are 36. I know the patient is critical and or red. I'm going to provide my treatments as far as an occlusive dressing, and then I'm going to move on to my next patient and ensure that I communicate back to incident command or my extrication team of where that patient is located. I come across my third patient. Respirations are 16, does have a strong radial pulse. We got minor abrasions in the hematoma of the head, and patient is altered. So based on the altered mental status, that patient will be classified as immediate. Now remember, once I get this individual into the treatment area, I am going to re-triage based on the resources that I have, the amount of patients that I have. So I have 2 patients prior that have gunshot wounds to the head and the neck, and this individual could have simply fell down, hit their head, and that's why they're altered. So I may re-triage this patient, put them in the yellow category because of their injuries are not as threatening as the other 2 patients that I've already come across. Come across patient 4, 28-year-old female, respirations 20. She is unresponsive, no palpable radial pulse. She's going to be classified as red. Radio this in, move on to my next patient. 42-year-old male, not breathing, no radial pulse, unconscious. First thing that I'm going to do is I'm going to rotate that patient into a supine position, and then I'm going to open up the patient's airway. If they are still not breathing, I'm going to take them as deceased, and then I'm going to move on to my next patient. So as far as leadership roles go within an MCI, we want to start creating our leadership structure. And again, we're going to be limited based on our capabilities and the amount of resources that we have. Once we start getting more resources in, then we can start building that leadership team and that hierarchy a little bit better. But within the leadership roles, based on STAR triage, we should have an incident commander, triage officer, staging officer, patient collection and/or treatment officer, and then also a transport officer. So the incident commander is going to be in charge of the integrity of that entire scene as far as building their leadership hierarchy, calling in additional resources, communication to the hospital. The staging officer is going to be located and positioned within the staging area, and they're going to be in charge of communication between the incident commander and then also the treatment officer as far as what resources are coming in. Now remember, when we call in additional resources, not every additional resource is going to have our specific radio channel, and so we want to signify to dispatch where the staging location is, so that when we have Ashland ambulance arrive on scene, they're arriving at the staging area. I'm now in charge of the staging area as the staging officer. I can communicate with the treatment officer saying, I have another ambulance here. Yep, send them up. We have 2 more patients that are ready for transport. I can send them in, they pick up their patients, then they start transporting. Patient collection officer and/or treatment officer is going to be in charge of that specific treatment area. Depending on how big your mass casualty incident is and how many resources, you may have multiple treatment officers. So remember, our span of control, as determined by NIMS, should be in between 3 to 7, ideally 5. So if we have a lot of resources and a lot of patients, I may have a green treatment officer, a yellow treatment officer, and a red treatment officer. And they are going to work directly with the transport officer. That transport officer, again, is going to be utilized by somebody from Mayo who's going to be determining where those patients are being transported, and then also notifying the hospital of what they're coming in with. So we're going to take a look at a couple of different case studies, specifically the Boston Marathon bombing and the Aurora movie theater shooting. So first, when we're looking at the Boston Marathon bombing, the timeline of events is at 2:49, the first bomb detonated. Very shortly afterwards, the second bomb detonated. Immediately, they called in a mass casualty incident. And for this specific case study, they had a lot of things that were going right off the bat with them. They already had an incident command and unified command system set up. They already had a lot of medical personnel that were on scene as far as treatment tents, docs, nurses, paramedics. They had 16 ambulances that were dedicated to the race itself. So again, they had all of their pieces already ready to go in the event that this MCI occurred. So within about 9 minutes, that first critical patient was transported, and within 46 minutes, the last critical patient was transported to the hospital. Now, how this was achieved was because they immediately set up a triage algorithm in a treatment area, and basically they separated this into 2 different areas. So they had where the first bomb went off and the second bomb went off. So they had 2 different treatment areas, 2 different triage areas, and then their unified command was actually in the basement of a government center, and that had fire, police, and EMS representatives in order to create that unified command system. Very shortly after those bombs went off, the hospitals were notified that they did have an MCI, and the hospitals were able to call in additional resources. They also requested additional resources in the forms of ambulances, and they got 73 additional ambulances to respond to that location. Now, we all know within Superior, Wisconsin, that if we request additional resources, that we are not going to get 73 ambulances. But keep in mind what resources that you can use. So we have Ashland, we have Cloquet, we have Lake County Ambulance, and then keep in mind all of those transport services that continuously transport to St. Mary's or St. Luke's. So notify St. Mary's or St. Luke's and see, which service is in the garage, because Hibbing, Virginia, Ely, International Falls, all of those are continuously driving back and forth from their base to St. Luke's or St. Mary's. So some positive takeaways: very strong relationship between police, fire, and EMS. As I mentioned, they had a lot of things going for them, and that was their revamping within their MCI protocols. So 2 years prior to the Boston Marathon bombing, a massive heat wave took place during the race. And as a result of that, they had a lot of patients suffer from heat emergencies and basically some MCI 2 years prior. So after that specific race, police, fire, EMS sat down with emergency management and other leadership stakeholders, and they revamped how they utilize the resources in the event of an MCI. 2 years later, the bombing occurs, and a lot of good things took place because of that. Communication was extremely solid. They were able to communicate between police, fire, and EMS at a second's notice. The triage treatment area is set up very well, and then the transport area is set up very well too, as far as getting those patients transported, especially the critical ones. So when we look at the run statistics, 118 patients were transported via ambulance. So again, they had a lot of good things going for them already. They already had all of this command structure set up. It was a nice day. They had roadways that were already blocked off because of the race. They had multiple hospitals that had level 1 capabilities. They had a lot of additional resources in the forms of ambulances. So that case study isn't extremely realistic within our area. More realistic would be the Aurora movie theater shooting. Now, when we're looking at this case study, there was actually a lot of negative takeaways behind this. Not bashing anybody, not Monday morning cornerbacking, but what we want to do as far as utilizing case studies is to identify our own limitations, learn from the mistakes of prior individuals, and then tailor that into our operational components.
Aurora police arrived at the scene of the shooting within 3 minutes of the emergency call. 5.5 minutes later, police make their first request for an ambulance. About 2 minutes later, another call for first responders, this time to treat a child who is critical and inside Theater 9.
I've got a child victim. I need rescue at the back door now. Back door Theater 9 will start him.
Unable to wait any longer, police start moving victims outside on their own.
We're bringing out bodies now. Get someone to the back as soon as you can. Rescue personnel. I got at least 3 to 7 hits.
Medics are again requested for the child police are worried about.
Again, PD is requesting medical personnel in Theater 9. They have a child down and cannot evacuate.
Quick-thinking police start transporting those critically injured to hospitals in police cars.
Metro 10, Lincoln 25. Do I have permission to start taking some of these victims via car? I got a whole bunch of people shot out here. No rescue. Yes, load them up. Get them in cars. Get them out of here.
At this point, more than 5 minutes have passed since the first request for paramedics to treat the critically injured child inside Theater 9. Still no first responders. Another plea for help from police.
We have one. We cannot move in Theater 9. As soon as they're available.
The Aurora Fire Department's first responders are on the scene just 5 minutes after the shooting. But for far too long, they are blocked from getting to the theater and those most critical by those less injured. A sea of wounded victims streaming into the parking lot stops paramedics in their tracks, leaving the most critical patients at the theater untreated. Aurora Fire Captain Al Robnett wouldn't go on camera with us, but told the Denver Post, quote, They were overwhelmed with patients. Patients were running towards them. They were covered with blood. We cannot move past a patient to get to another patient. Remember the child police say is in desperate need of a medic? Another request for help goes out.
PD is again requesting emergent medical to the back of the theater. I copy that. I'm just trying to get things under control here.
And another.
I apologize again. PD is asking for emergent medical to the back of the theater. I believe that they have another party inside Theater 9 that they can't evacuate, which is the child, but they have 10 parties down behind the theater, is what they're saying.
At this point, they are about 20 minutes into the shooting chaos. Still, no rescue teams on site at Theater 9. Emma Goose managed to escape the theater. She told Anderson Cooper about one critical victim she saw wandering the parking lot untreated.
He was asking for help and no one would stop to help him, and I thought, well, I have to at least talk to him. I'm not trained in paramedics at all, but I should talk to him. And I went over and he had been hit in the head.
Dispatch tapes also indicate a breakdown in communication between police and fire. Police clearly knew there were dozens shot, but a fire commander tells dispatch there are perhaps just 20 victims.
Do we have an approximate patient count at all? I'm just trying to sort out right now. I'm hearing 10 here, 4 here. I'm going to go with 20 for right now. Let's just go with 20 people until we get this verified.
22 minutes into this, rescue teams and the fire department are still clearly overwhelmed.
We have 9 shots. If we can get any ambulances to stay unstable, we can get them over to the ambulance. Okay. Just stand by. Let me get this sorted out. I'll get you with you in just a minute. Just hang on.
Finally, nearly 24 minutes after shots fired, ambulances arrive at the theater's back door.
I'm rolling in now.
Really gives you a sense of the chaos there. Randy joins us now live from Aurora, Colorado. On the dispatch tapes, did they ever identify the child that they were trying to save?
No, Anderson, they never ID'd her. They never said who she was, but we can only guess that it was Veronica Moser Sullivan. She was the 6-year-old who died in this theater shooting. There were no autopsy results released, so it's hard to know what her injuries were and what maybe possibly if she could have been saved if they had reached her sooner.
And any response from emergency responders about the delays in treatment, because the police seem to be on the scene immediately.
Right, the police were there within minutes. We did get a statement just moments before we went on air from the city and from EMS telling us that they also arrived within minutes, that they started treating patients immediately. And that's true. We reported that in our story. You just heard that. But what they don't identify is which patients. It could have been the patients in the parking lot. It wasn't the patients who were critically injured who were at the theater, because you have to wonder that why would the police be calling for ambulances over and over and over again, Anderson, for more than 20 minutes if they were staring at an ambulance right there in front of them? So clearly they weren't there. They did say, though, that all of the patients were en route to the hospital within 55 minutes.
Yeah, a lot of confusion, obviously. Randy K., appreciate it.
All right, again, a little bit more realistic for those of you who are not familiar with Aurora. Aurora is very similar to the size of Duluth. And then their resources that they have are similar as well, where they have municipal fire, municipal police, and then they have a private ambulance service. So breaking down the timeline of events, 12:38 is when the shooting began. 911 calls were made almost immediately. Police were on scene within about a minute or two. And that's because police headquarters was actually just a couple of blocks away from the movie theater. 12:42 is when fire and EMS arrived on scene and they were staging. So how the first 911 call was actually made was that they described a single patient was shot. And as a result of that, dispatch only sent one engine company, one battalion chief, and one ambulance, and they were staging. 12:54, after multiple attempts, they began transporting via police vehicle. It wasn't until 12:55 that we actually heard dispatch information from that battalion chief that established incident command of this incident. And then it wasn't until about 1:30 in the morning that they actually set up unified command between police, fire, and EMS, because they could not communicate with each other. Very similar with Mayo, where we have to contact our dispatch has to contact their dispatch, and then their dispatch contacts a specific rig, is the same thing that was occurring here. Now again, not to blast any of our brothers or sisters on anything like this, but this was a very dynamic scene where instead of Boston Marathon bombing, where it was wide open, we were outside, it was a nice sunny day, it was dark, movie theater, active shooter. They didn't exactly know where that active shooter was. But when we're taking learning moments out of this is proper communication channels between the three entities that we're utilizing, make sure that we can communicate with one another. They had a very lack of triage and training between them. So as far as triage goes, the only triage that took effect was a SWAT medic that was inside Theater 9. The rest did not actually occur. So you could hear that quote from that captain was they started treating and transporting the patients that were classified as green because he said that we couldn't move on to the next patient. Well, that's technically false because that's what triage is we're differentiating who's critical and who's not, who's the priority as far as receiving care and transport. In all, 60 patients were transported, 20 by ambulance, 28 by police vehicle, and then 14 by private vehicle. They did have a lack of ambulances that were available at that time. So again, just some takeaways. Based on penetrating thoracic injuries, let's go ahead and review the hyphen chest seal. And this does a good video of showing the pathophysiology behind tension pneumothorax.
Introducing the hyphen chest seal from North American Rescue. The hyphen chest seal is a self-adhesive occlusive dressing designed specifically for use in the management of casualties with penetrating chest wounds. The hyphen utilizes the latest specialized adhesive technology in order to achieve and maintain a superior seal under the most adverse conditions. The hyphen is supplied in a rugged, easy-to-open foil package that allows for quick and effective application in extreme environments. After action reviews from numerous healthcare professionals identified the recurrent requirement for an occlusive dressing that effectively adheres to a casualty's chest wall, the hyphen chest seal was developed, tested, and validated through an extensive collaborative effort with these providers to achieve this requirement. The hyphen chest seal meets the Committee on Tactical Combat Casualty Care's current guidelines for managing all open and/or sucking chest wounds. A penetrating chest wound creates an opening in the chest wall through which air may enter the chest cavity during the normal respiration cycle. Commonly referred to as a sucking chest wound, this injury results in a condition known as an open pneumothorax. An open pneumothorax occurs when there is a persistent communication between the internal thoracic cavity and the environment through a defect in the chest wall. Though this interferes with normal physiological ventilation, it should not create a tension pneumothorax, as the intrathoracic pressure and the atmospheric pressure equalize across the open wound. A tension pneumothorax can develop with a sucking chest wound, when the chest wall defect creates a one-way valve in which air can be drawn into the pleural space but cannot exit. Since the air cannot escape, the intrathoracic pressure increases, and a life-threatening tension pneumothorax can develop. The initial management of an open and/or sucking chest wound is to immediately apply an occlusive dressing to cover the defect and secure it in place. Traditionally, an occlusive dressing secured only on 3 sides has been used to seal penetrating chest wounds to help in preventing a tension pneumothorax from developing. Other types of chest dressings, some which contain pressure relief valves, are also in use, but there is little clinical evidence to show that any of these, or even the traditional 3-sided dressings, are superior to a completely occlusive dressing placed over the wound to cover the defect. Bleeding from the wound site, continued sweating, body hair, and other environmental contaminants may significantly limit the effectiveness of adhesive devices not designed to overcome these adverse conditions. The hyphen chest seal was designed with superior adhesion capabilities to conquer these challenges. This casualty has sustained a penetrating chest wound to his anterior chest with no exit wound. His lung has collapsed, and it is interfering with his ability to breathe. He requires the immediate application of a hyphen chest seal. These wounds are rapidly treated by applying a hyphen chest seal during expiration, placing the casualty in an upright position or in the recovery position, and monitoring his respirations for the possible development of a tension pneumothorax. Step 1. Wipe any dirt and/or fluid from skin with sterile gauze pad. Step 2. Grip large white flap and peel clear liner from dressing. Step 3. Place dressing on patient, adhesive side down, centered over the wound. Step 4. Peel and remove small white flap. Step 5. Firmly press dressing to skin, forming an effective seal. Position the casualty in either a sitting position or the lateral recumbent recovery position. Because air may still enter the chest cavity through the damaged lung tissue during the normal respiratory cycle, the attending medical provider continuously observes and monitors the casualty for signs of progressive breathing difficulty that may indicate the development of a tension pneumothorax. If the provider becomes concerned for a developing tension pneumothorax, they should follow their training and established protocols to treat this condition. Supporting tactical and pre-hospital healthcare professionals worldwide and enhancing casualty survival by providing superior products used specifically for austere environments is our
All right, so been talking over an hour now, so let's take a break. We will meet back at 11:15, and we're going to start diving into some of the medical stuff. All right, thanks everybody.
This conference will now be recorded.
So this lecture, we're going to specifically identify, utilizing differential diagnosis based on our patient assessment and findings, and then utilizing our sample history and how vitals correlate to each specific medical emergency that we're most likely going to encounter. So one, altered mental status is a significant finding that we see in a lot of our patients, and there's a variety of different reasons why an individual may experience altered mental status. So before we continue, question from station 2, is Trendelenburg still common practice for shock treatment? And that is not a common practice for shock treatment. It is not being utilized. There's too many negative ramifications behind the Trendelenburg position. Specifically, when we put the patient's legs up, it negatively impacts their diaphragm and how they breathe properly. Other things that can actually interfere with the proper preload and the afterload of the patient's heart. And then with all the documentation and report and statistics behind it, the positive impacts were very, very limited as far as getting a patient treated for shock utilizing that position. So with altered mental status and the brain function, we really need three things. We need sugar, we need water, and we need oxygen in for that brain to survive. So things that can interfere with those three things is we could have a significant medical emergency or a traumatic head injury, heart rhythm disturbances, dementia. Remember, dementia is a blanket term which covers a lot of different other altered mental status, whether it's Alzheimer's or other disease processes that interfere with the brain function of the patient. Infection, UTIs, medication-related, decreased blood volume, hypoxia, hyperthermia, and then of course our blood sugar values as far as our diabetic patients go. So when we're utilizing differential diagnosis, what we're trying to eliminate is common medical emergencies to try and pinpoint us in the right direction as far as our treatment plan for a specific patient based on our findings and then the sample history and what their vitals are trying to tell us, both subjectively and objectively. So we're dispatched, 64-year-old male patient not acting correctly. Upon scene arrival, you find the patient sitting in a chair and his wife is on scene. Patient is alert but unable to communicate clearly. Patient has obvious right-sided facial droop and is unable to move his right extremities. Patient's pulse ox is at 96%, blood sugar 84, heart rate 82, and blood pressure is elevated at 164/92. So utilizing my differential diagnosis based on the patient's assessment displays as far as the facial droop, that's starting to steer me down the path of stroke. However, I'm still going to eliminate other common causes based on my vital signs and my history taking. So as far as having that altered mental status, I know it's not hypoxic because the patient's SATI 96%, breathing properly. I know it's not diabetic related because the blood sugar is adequate. Heart rate's strong and regular, so most likely it's not a heart rate or rhythm disturbance. But again, starting to pinpoint that this most likely is a stroke related patient. So diving deeper into my treatment and assessment plan for this, I'm going to go ahead and conduct my Cincinnati stroke scale, and I do determine that patient's got facial droop, slurred speech, and then unable to control the right side of his body utilizing that arm drift technique. So when we're looking at stroke classification, we have two different types of stroke. We have ischemic and we have hemorrhagic. Ischemic is going to be the result of a blockage within one of the blood vessels that feeds blood to the brain itself. Hemorrhagic stroke is going to be from a burst blood vessel, and as a result, a lack of oxygen is going to get depleted to certain portions of the brain. So with stroke, remember, it's going to affect one hemisphere, and that's why we see the signs and symptoms only affect one side of the patient's body. So our signs and symptoms: slurred speech, facial droop, extremity paralysis on one side, and then a lot of patients, especially if they suffer from hemorrhagic stroke, will describe the worst headache that they've ever experienced. As far as treatments go, maintain proper oxygen therapy, make sure that we are ready to go as far as providing CPR in the event that they go into cardiac arrest, and that's pretty much it. Our assessment question should tailor around too, as far as when the signs and symptoms started and or when was the last time the patient was seen normally, because we only have a small window as far as providing fibrinolytic therapy for our patient. Now within our protocols, remember, we do have aspirin if a patient's experiencing chest pain and they're also displaying signs and symptoms of stroke. Make sure that we are not providing aspirin in that patient, because we cannot differentiate whether it's ischemic or hemorrhagic. So if I gave aspirin to a patient who's suffering from a hemorrhagic stroke, I just made that problem exponentially worse. We are dispatched to a 23-year-old female patient, altered level of consciousness. Upon scene arrival, you find a patient lying on her side on the kitchen floor. Patient is unable to answer questions at this time. Boyfriend on scene said patient was standing in the kitchen, fell to the floor, and started jerking violently. Boyfriend does not know her medical history, but you do find a bottle of Klonopin. So utilizing our differential diagnosis based on the information from the boyfriend, I am starting to steer my assessment and my treatment plan down that seizure route. Other information that I specifically want to know is, did the patient seize and then fall, or did they fall, hit their head, and then seize? Because remember, we have a variety of different reasons why an individual can go into a seizure. So we don't know a specific medical history, but we do find a bottle of Klonopin. Now, Klonopin is used for seizure disorders, specifically epilepsy, but it is utilized for other things such as anxiety and some other mental disorders as well. So hopefully we actually have some medical literature based on the patient from either St. Luke's or St. Mary's, based on what the Klonopin specifically is used for. Now, other things that I want to know how long that seizure lasted and the specific signs that the patient was presenting with when they were seizing, because there are different seizure classifications. So with their generalized seizure or tonic-clonic, this is going to be that full body movement. Both hemispheres of the brain are going to be affected. And as a result, we're going to see muscle contraction and muscle relaxation. When we have different types of seizures that affect only one hemisphere, we could be looking at complex partial seizures. So again, one hemisphere of the brain is going to be affected. So we're going to see one body system affected or one side of the body affected. With absence seizures, a patient is actually seizing, but not displaying the typical signs and symptoms. So most of the time, they're just staring off into space. Febrile seizures, this is going to be a mark specifically with our peds and our infants where we have an increase in body temperature. And because of that increase, we see febrile seizures. Now, most of the time, febrile seizures are 30 seconds or less. They resolve on their own. And with febrile seizures, it's not necessarily the increase in the body temperature, but it is that short change within that body temperature. So it's that drastic increase, not necessarily your patient having 103 temperature, but it's that drastic rise from 98 to 103. And then severe emergencies, when we have status seizures, where that patient continuously seizes for an extended period of time, and or they seize and don't regain consciousness, and then seize again, don't regain consciousness, seize again. What seizures are is it's an abnormal electricity rhythm within the brain that causes this. And when that electricity is traveling so fast, it actually impacts the brain stem. And so patients don't breathe very adequately on their own. Once that seizure is stopped, that electricity within the brain actually starts to regain normal capacity. The patient goes into the postictal phase and they start to regain their bearings, get that oxygen saturation up, and then start functioning properly again. Depending on how long that seizure has lasted is going to be dependent upon how long that they're in that postictal period. So be ready to give oxygen therapy. Make sure that we're checking a blood sugar on these patients because a couple of different reasons why seizures can occur. First and foremost, we have epilepsy, where that individual is disposed of having seizures, extremely low blood sugar, head injuries, toxins, and then other medication interference as well. Your dispatch, 63-year-old male patient complaining of chest pain, has now lost consciousness. While en route, dispatch notifies you that the patient is not breathing according to the reporting party. Upon scene arrival, you find the patient lying in a supine position. Patient appears pale, diaphoretic. Further assessment, no pulse, no breathing. Patient's wife is on scene, stated that patient been complaining of chest pain and shortness of breath, but did not want to go to the doctor. So utilizing our differential diagnosis, this is immediately steering us into our American Heart Association basic life support treatment and care. So we've identified the fact that this individual is in cardiac arrest. So go through our basic life support sequence of providing compressions, ventilations, AED usage, and then advanced airway management. Now, as far as our captains go, and if we have additional resources, let's try and find out the reason why this individual went into cardiac arrest by identifying one of the H's and T's. So remember, our H's and T's are the common reasons of individuals going into cardiac arrest. So for our H's, we have hypovolemia. So we got low fluid, internal or external bleeding. Hypoxia, low oxygen content. Hydrogen acidosis has to do with the pH balance of the system, whether they're acidotic or not. Hyper or hypokalemia is high or low potassium levels. Where we see that the most is patients on dialysis treatment, and that really plays havoc with their potassium levels, especially if they've missed consecutive dialysis treatments. Potassium is one of the main elements that actually makes the heart function properly, so that could send them into cardiac arrest, whether they're high or low. And then, of course, hypothermia, which isn't going to change our treatment plan. And then our T's, so we got toxins such as our drugs like our opioids or our hazmat materials, tension pneumothorax, cardiac tamponade, and then our thrombosis, our blockages, so both coronary and pulmonary. And based on the information that the wife presented, she was saying that patient was complaining of chest pain and shortness of breath prior to going down. So it's leading me to believe that most likely it is a coronary thrombosis or a myocardial infarction that started this whole sequence and sending that patient into cardiac arrest. Other cardiac emergencies, angina. Angina is a very simple term that means pain in the chest. So these patients are going to be prescribed nitro. Most of the time it's going to be relieved with that nitro because it's a lack of oxygen to the heart muscle itself. And then when we have myocardial infarction, where we actually have a blockage, remember our treatment plan is going to include aspirin, oxygen therapy as needed. Aspirin is going to make the blood a little bit more slippery to get past that blockage. Congestive heart failure, where we have a portion of the heart muscle that is no longer strong enough to pump an adequate amount of volume from the specific chamber that it's in charge of. Where we see this most often is with the left ventricle, and eventually that preload of that heart begins to build up and back up in the different chambers of the heart. So when we have a CHF patient, they're complaining of shortness of breath, we notice pedal and pulmonary edema, chances are that fluid buildup is starting to get to different portions of the body. You're dispatched for a 45-year-old male patient, ultramental status, cool and diaphoretic. On arrival, you find a patient standing in the garage. It's a warm summer day, been working in the yard. 911 call was made by a neighbor who was watching him cut the grass without the mower on. Patient's confused, breathing adequately, has a strong radial pulse. So based on this information, this can lead us down a number of different routes. Could be a stroke, could be an MI, could be diabetic, could be environmental, could be hypovolemia. So we need to do a good thorough job as far as our patient assessment, our sample history, and gathering up our vital signs. So we determine that the patient is diabetic. We check a blood sugar, and the blood sugar is at 36. So we've identified that the reason most likely of the ultramental status is from having low sugar content. So we do have 3 different types of diabetes. We have type 1, type 2, and gestational. Type 1 is going to be an insufficient insulin production. Type 2, still producing insulin and can be regulated with exercise and proper dieting. And then gestational diabetes gets developed within pregnancy, but will resolve on its own once that female has given birth. Now with gestational diabetes, if a female does have that, there is likelihood they'll develop type 2 diabetes at some point within their life. Now, are we overly concerned whether somebody's type 1 or type 2? Not really. What we need to treat is the fact that their blood sugar is either too low or too high and it's not sustaining perfusion properly. So there is quite a difference between signs and symptoms for hyperglycemic patients and our hypoglycemic patients. Hypoglycemia generally is marked by pale, cool, diaphoretic skin. Most of the time it's acute or a rapid onset. And then we can see kind of that intoxicated signs and symptoms as far as slurred speech, agitated, altered mental status. Hyperglycemia, generally we're going to see more hot or flushed skin. Could still see an altered mental status. And then this is going to take quite a bit longer to develop. So this is going to be over time. A lot of times the patients are complaining of weakness, increased hunger, increased thirst, maybe a loss of weight. And then if we smell that fruity breath, that is a sign of diabetic ketoacidosis, in which they've maintained a blood sugar value over 400 for an extended period of time. So as far as treatments go, if we can, utilize oral glucose if they can protect their own airway, increase that sugar value. Hopefully they do have insulin within their system so that it can uptake that blood sugar and then convert it into energy. Remember, contraindications with oral glucose, if they can't swallow or protect their own airway, we do not want to utilize that. Once we do get that sugar up, Patient's now alert and oriented. Make sure that we get some type of substance, peanut butter and jelly sandwich, glass of milk, in order to sustain that blood sugar value. Now, once we get that individual to eat, prior to actually leaving that patient, make sure that that individual is taking their own blood sugar with their own glucometer. And that way we can ensure that this individual can care for themselves when we leave, and then also their glucometer is displaying an accurate reading. So normal blood sugar values, diabetics are kind of like snowflakes. Everyone is learning as far as what their normal values are. So when you're doing your sample history, make sure that you're asking them what their normal blood sugar value is to compare it based on your findings. Your dispatch for a 16-year-old male patient at the high school for difficulty breathing. Upon scene arrival, you find the patient sitting in the nurse's office with audible wheezes upon inspiration. Patient was at lunch prior to the onset of symptoms. Patient has hives throughout his body and his face is beginning to swell. So based on this information, it's kind of steering me down the route as far as an anaphylactic reaction, because he was at lunch, he was eating, he's displaying signs and symptoms of hives, and he's also showing signs of swelling. So within my sample history, I asked him if he's got any allergies, and he confirms that he was allergic to peanuts, and there may have been a possible exposure to those peanuts. So then I'm going to go through my sequence as far as treatment with oxygen therapy and then providing epinephrine. What's going on inside the body, and I touched on this a couple of presentations ago, is the introduction of histamines are going to cause my signs and symptoms associated with this. So moderate signs, you can see itchiness, hives, localized rash, going to see an increase in heart rate, where it turns into severe and anaphylaxis when we have multiple body systems that are being affected, specifically if we have vasodilation with poor perfusion, and then that bronchial constriction, which is going to be associated with our wheezes. So we got to be ready to go as far as providing that treatment with an epinephrine. So remember, epinephrine is going to take away the two major signs and symptoms. It's not necessarily going to take away the reason why this individual is suffering from anaphylaxis. So it's going to be a vasoconstrictor, which is going to bring up that blood pressure, and it's going to be a bronchodilator, which will make it easier for that patient to breathe. So our epinephrine dose for adults is going to be 0.3 milligrams. Pediatric dose is 0.15 milligrams. It does come in a 1-to-1 solution. So if I drop 0.3 cc's, that's 0.3 milligrams. Administration, we're going to give that into the arm, either musculoskeletal and or subcutaneous. We should see those desired effects relatively quickly. We can also follow up that treatment with a bronchodilator such as albuterol, utilizing our nebulizer masks as well. Remember, epinephrine is going to last about 15 minutes throughout the body. The histamines inside the body are going to last longer. So you may have to administer another dose of epinephrine. Make sure that you put that other dose in the other arm than your first shot that you gave. Dispatch for a 47-year-old female with back pain. Upon scene arrival, you find the patient in a tripod position. Patient stated that her pain is located in the center portion of her chest, or excuse me, back. Described as a tearing pain, 10 out of 10. She's showing signs and symptoms of shock as far as pale, cool, diaphoretic skin. She's anxious, and then she has that impending doom symptom. So based on that information, we got to keep in mind that with cardiovascular emergencies, sometimes females will display signs and symptoms that are not your typical signs that you see with male patients. Male patients very predominantly will display signs of chest pain, shortness of breath, and radiates to their jaw and or their arm. Females can be complaining of abdominal pain, back pain, especially our geriatric diabetic female patients display very abnormal cardiovascular symptoms. But based on this patient's presentation, what I'm starting to be concerned about is if this patient has a AAA. So a AAA is going to be an abdominal aortic dissection from an aneurysm. So that lining within the aorta is going to begin to balloon, and eventually, if it is not caught, it is going to go ahead and burst. And so all of the blood that is being pumped out by the left ventricle is going to go ahead and escape out of this penetrating injury within the aortic lining. They are going to display signs and symptoms of looking like crap and right on the verge of most likely going into cardiac arrest. So as far as assessment findings go, we want to palpate the abdomen, look for any distension. And then also another good finding is checking the blood pressure on both sides. So I'm going to take the blood pressure on the left, take the blood pressure on the right. If they're significantly different, that is an indication that it is a AAA. So there is perfusion going through the aorta, through the blood vessels to one side, but it's negatively being affected to the other. And that's why we see those changes within the blood pressure on either side. Other abdominal injuries, kidney stones, extremely painful, marked by abdominal pain, nausea, vomiting. When we do have any type of abdominal emergency, make sure that we're doing a good job within our assessment as far as inspection, palpation. Whenever we're palpating, always start farthest away from where that pain is. And we're looking for rebound tenderness as well. Here's that example of that aorta shearing from the ballooning and eventually dissecting. So you're dispatched, 25-year-old male patient, unresponsive, unknown breathing status, no medical history that you know of, address is flagged for drug abuse. Seen, you find your patient, they are apneic. You have signs that there is track marks up and down the patient's arm. You inspect the pupils, they are pinpoint. All right, this is leading us to believe that it is an opioid-based overdose at this point. First and foremost, let's fix the breathing and the airway. So open up that patient's airway and assist ventilations at one breath every 5 to 6 seconds. High flow oxygen, be monitoring that pulse oximetry. Eventually we can get down to that Narcan route. Now keep in mind that Narcan is being administered to a lot of family members who have loved ones who do suffer from opioid addiction. With opioid addiction and administration of Narcan, we got to be thinking of our patients and how they maintain homeostasis. So if I have a patient who is absolutely addicted to opioids, their homeostasis has changed to always having some type of opioid in their system. And that's how they maintain their normal behavior. So a family member has given patient 4 milligrams of Narcan. Law enforcement has given 8 milligrams of Narcan prior to our arrival on scene. I am going to delay myself giving Narcan for an extended period of time, and I'm going to focus on the airway and the breathing in hopes that that Narcan catches up with that patient. Because what Narcan is going to do is all of the brain receptors that are attached to opioids, they are going to bump those off. And then all of the brain receptors that are not currently being attached by opioids, they're going to block them. So if I have a shit ton of Narcan inside this patient's body, I am depleting all of the opioids inside their brain receptors. And as a result of that, I'm basically eliminating what their normal homeostasis level is, in which I could send this patient into withdrawal symptoms. They could experience seizures and even cardiac arrest. Other types of drug overdoses, as we know, opioids are the most common overdose that we're going to experience right now, marked by pinpoint pupils, decrease in mental status, decrease in respiratory drive. Other overdoses, where we can identify it easy enough with both our sample history and then also looking at the pupils. So generally our downers, our narcotics, our opioids, they're going to have constricted and or pinpoint pupils. Our uppers, such as our ecstasy, our cocaine, our speed, they're going to have those dilated pupils. Red eyes, oftentimes marked by marijuana, and then benzodiazepines and depressants. So your dispatch, 29-year-old male patient acting aggressive and violent. Law enforcement is on scene. They have restrained the patient. Law enforcement has advised that heavy amounts of synthetic drugs have been found on the scene. So what else we want to know? We want to try and identify specifically what synthetic drug it was, and then we're going to dive into our patient assessment and our history taking. So with synthetic drugs, my number one concern for my patients is going to be if they're experiencing excited delirium. So excited delirium is going to basically put that brain on overdrive. It's going to increase the electrical activity. It's going to increase the body temperature, increase the heart rate, increase the blood pressure, and increase the heart rate. So the body can only take so much, and the body temperature can only be so high before that patient goes into cardiac arrest, especially with that increase in electrical impulses going through that brain. So with excited delirium, they're going to be showing signs and symptoms of severe agitation, a severe body temperature increase, altered mental status, and when they're fighting against an individual who's restraining them, that could send them into a cardiac dysrhythmia, where that patient actually goes into VFib or VTAC in cardiac arrest. So other behavioral and psychiatric emergencies, normal behavior is what normal individuals exhibit, and as a result, they function normally in society. When there's a behavioral emergency, they are either a threat to themselves, the community, and or bystanders and EMS providers. So anxiety, very common, a state of uneasiness, and this is contributed to the adrenal gland, which we continue to drop adrenaline inside of this system. Phobias, going to be irrational fears. Generally, this is going to be from benign objects, and then this is going to be a state of uneasiness too, and specifically focusing on that event. Depression, caused by an imbalance of chemicals that are within the brain, specifically within our serotonin, dopamine, norepinephrine levels, that can cause that individual to become depressed, or we're concerned not only for our patient, but also if they have suicidal ideation. Bipolar disorder, manic depressant followed by manic activity. And so we go from extreme lows to extreme highs. Acute psychosis can be brought on by medication, drugs, and in which they are displaying hallucinations, delusions, or a type of thought disorder. Similar to that is schizophrenia, but this is a chronic condition where that patient actually doesn't go back to their normal behavior or normal homeostasis level. You are dispatched for a 25-year-old female patient in active labor. Upon scene arrival, you find the patient lying in a semi-Fowler's position in an inflatable swimming pool in the living room. A midwife is on scene, states that she couldn't get the baby out, and abruptly leaves. You assess your patient, find a foot presenting. Patient is alert, breathing, and has a strong radial pulse. Mother, what are we going to do? So with OB emergencies, a couple of different ones. First, ectopic pregnancy, where that implanted egg gets implanted somewhere other than the uterus. Major concern is if it gets implanted in the fallopian tubes, there can be some pretty negative ramifications. That's going to be marked by significant abdominal pain, bleeding, and then that individual, as far as your sample history, is going to be off on their menstrual cycle. Spontaneous abortion, if that female actually rejects that developing fetus, can be marked by bleeding, abdominal pain, and then also remember your emotional and supportive care for somebody like that. Supine hypotensive syndrome, with that fetus developing and then the increased weight, if mom is laying on her back and then the baby is resting against the superior and inferior vena cavas, it can really drop the blood pressure. So when we're looking at second and specifically third trimester, we're transporting our patients, make sure that they are in a left lateral or right lateral recumbent position. Preeclampsia, is going to be indications of severe hypertension. And if that is not treated, it can lead into eclampsia. So this is a significant hypertensive emergency in which it can cause seizures, coma, and then it could send that patient into cardiac arrest. Abruptio placenta is when the placenta separates from the uterine wall prior to the delivery of the fetus. This is going to be marked by a heavy amount of bleeding and a heavy amount of abdominal pain. And so if it occurs, then baby has lost the lifeline in between mom and baby. So this is a significant emergency. They only have enough blood perfusion that's within the placenta, and they can't actually get any more from mom. Placenta previa, this is when the placenta is actually going to be developed over the opening of the cervix. We don't see this very often because hopefully this individual is receiving prenatal care, and in which case, if they did get scans, they should be able to identify where that placenta is, and hopefully this patient is down at St. Luke's or St. Mary's, or not St. Luke's, St. Mary's, the U of M and or Mayo Clinic receiving care. Uterine rupture, this is actually going to take place after mom is delivered. This can be caused from sneezing or coughing because the uterine muscle tissue is actually going to be damaged from actually giving birth. And then breech presentation, as we've seen in this scenario, or anything besides the head is actually being presented. So if we do have a breech presentation, try and delay the effects of birth. So try and coach mom not to push. And then captains, go ahead and give St. Mary's a call, ask to talk to an OB doc, and see if there's a specific position that we can place mom in to delay those effects, and or if mom's really deteriorating, ask them what position that we can put them in order to facilitate that birth. You're dispatched for a 72-year-old female patient for weakness. Upon scene arrival, you find the patient sitting in her living room. She is alert but confused, displaying signs of generalized weakness, pedal swelling. You note that the patient is living alone, do not find any form of transportation in the driveway. When you go to take vital signs, you go to take blood pressure on the right side, and patient states that don't take it on that side, I have a shunt. So now we know that the patient does have renal failure. When asking as far as transport to dialysis, she hasn't been able to receive dialysis over the last several days because she hasn't had any transportation. So with renal disease and with our patients who receive dialysis treatments, think of what the kidneys do for the body. And the kidneys filter out the blood and toxin material and then pass it. So when somebody's got renal failure, their body, their kidneys cannot actually excrete and remove those toxins. And that's where dialysis comes in. So the blood is actually filtered out with dialysis machines and then placed back in the patient. So if the patient has missed multiple dialysis treatments, then those toxins will actually build up inside the system. And so we could actually see that patient go into septic shock from that. And then again, it's going to play havoc with their different electrolyte balances, specifically with potassium. Remember, with shunts, never take a blood pressure on the same side of that shunt. All right. Before we break for lunch, does anybody have any questions or concerns at all? All right, let's go ahead and break for lunch. We'll get started again at 1. I have 2 more lectures that take about 30 minutes each. We will be done at 2, and then I'll give you your homework assignment for the evening. So I'll meet you back here at 1 o'clock.
This conference will now be recorded.
All right, it's 1 o'clock. We got 2 more lectures that we're going to get through relatively quickly because I am sick talking to myself and looking at this. So does anybody have any questions or comments before we get too deep into pharmacology. All right. So pharmacology, we are going to be going through all of the EMT medications within the scope of practice set forth by the National Registry and by the specific states. So we will be going over medications that are not in SFD protocols and guidelines. However, there is always that chance that they can be added by Dr. Zadi. So first, when we're looking at key terms, medications, drugs, those are a specific substance utilized for a remedy in a specific medical diagnosis. Pharmacology is going to be the study of said drugs, and then the administration is going to be the EMT or EMS provider specifically giving that medication. So when we provide epinephrine and or Narcan, we are administering that medication. When we hand over aspirin to our patient, that's going to be the assistance of said medication. Now, assistance, administration, regardless, make sure that we're going through the 5 rights of medication administration prior to actually giving that med. So the meds within the EMT scope of practice, we have oxygen, we have oral glucose, aspirin, activated charcoal, albuterol, nitro, epi, and Narcan. So first with oxygen, odorless, tasteless gas. We all know that there's 21% oxygen within the room. Now, as far as utilizing it for treatment and therapy, there's 4 different routes that we can go ahead and give this. Nasal cannula, non-rebreather, bag valve mask, and nebulizer treatment. So when we're looking at the specific percentage of oxygen, when we're giving it via nasal cannula, we set it in between 1 to 6 liters per minute. We're giving about 24 to 44% supplemental oxygen. Given it non-rebreather mask, we're going to set that in between 10 to 15 liters per minute, and that's going to be roughly about 90% oxygen. When we give it via bag valve mask going to set at 15 liters per minute. That's going to be roughly in between 90 to 100%. And then with our nebulizer treatments, make sure that we set that at 6 liters per minute, and that's going to give right around 25% supplemental oxygen. So our indications for oxygen therapy, specifically hypoxia, hypoperfusion, contraindications in the event that somebody doesn't need oxygen. And we're focusing more and more in on providing supplemental oxygen to patients who have oxygen saturations that are less than 94%. Because if an individual, even if they're complaining of some shortness of breath and they're satting okay, and again, okay means above 94%, then we can withhold that oxygen therapy. When we continuously saturate somebody at 100% oxygen, what we're doing is we're introducing free radicals inside of the system. And that really hinders tissue perfusion within that, and it can also lead to cell permeability. So try and maintain 94 to 99 when we are providing supplemental oxygen, titrate to effect. Remember that our pulse oximeter can give us false readings such as carbon monoxide poisoning and then that lack of perfusion. Oral glucose, simple sugar complex. It's going to increase the availability of sugar within the bloodstream. Indications is going to be hypoglycemic patients. Contraindications, make sure that they have an intact, that they are at least alert enough in order to protect their own airway and then also follow commands. So it's going to absorb through the cheek. Sugar is going to enter the bloodstream. Hopefully that patient does have insulin or insulin production to uptake that sugar and then convert it into energy. Dose is going to be 15 grams. The route that we're going to give is going to be orally. Activated charcoal, we utilize this in the event that we have a poisoning overdose that is ingested via orally. So very limited indications that we can utilize this for, and that is going to be, again, ingestion of a substance It's got to be within 60 minutes, and it cannot be any type of caustic substance. So what activated charcoal is going to do is it's actually going to bind around the substance in the stomach before it is broken down, and then it's going to bind around that and then facilitate through the GI system so that our large intestine and our small intestine doesn't actually absorb whatever that patient took by mouth. Our dose is going to be 25 to 50 grams. This is given orally. For a pediatric dose, it's 12.5 to 25 grams. I have never had a patient actually finish an entire bottle because apparently it tastes like crap. This is not commonly used for in emergency services anymore. There's too many negative ramifications that they're starting to find out. It is playing a little bit too much negative ramifications with the GI system, and then it can also induce vomiting. Aspirin, utilize this for our cardiovascular patients, specifically displaying signs and symptoms of chest pain. It is a tablet medication in which each tablet is 81 milligrams for a total dose of 324 milligrams. Mechanism of action is going to be that antiplatelet effect, allowing for more blood supply and as a result, more oxygen getting in the affected heart muscle. Contraindications, stroke-like symptoms, severe GI issues, specifically bleeding ulcers. Hopefully their primary physician has advised them based on their medical diagnosis as far as whether they can take aspirin or whether they can't. Bronchodilator, albuterol, mechanism of action is opening up those bronchioles, and it does have some effects as far as drying up secretions. So our patients who have rales, crackles, we can also utilize albuterol because it is going to have some of that drying effect. Our dose is going to be 2.5 milligrams in a 3 milliliter solution. We can give this up to 3 times. Make sure that we are reassessing our patient after each administration. Reassessment should include auscultation of those lung sounds and then also getting a severity scale based on how bad their difficulty breathing is. So our indications when we hear abnormal lung sounds, specifically when we hear wheezes or rales or crackles, that is strong indications. And then don't forget that we can use this with epinephrine as far as making those bronchioles bigger and bigger. Contraindications, altered level of consciousness, not breathing adequately. I don't believe I wrote within our medical guidelines that we can utilize this with a bag valve mask. The patient's got to be spontaneously breathing on their own and being able to protect their own airway. So our contraindications also include hypersensitivity or allergic reaction, and then also anytime that the heart rate is above 160, do not utilize this because this is going to act on the beta-2 receptors, and that's going to increase the heart rate. So if an adult patient is at 160 beats per minute, we give albuterol, there is a chance that we could send that patient into SVT. Now the routes or ways that we can give it, we have the handheld nebulizer and or we have the oxygen mask nebulizer treatment. Preferred that we give the handheld because we get more medication inside that patient's lungs in comparison to the mask style. Nitroglycerin used in line with aspirin for cardiovascular patients experiencing chest pain. What it does is it's a vasodilator. So it makes the patient's blood vessels bigger so that we're getting more blood flow to the specific portion of the heart muscle that's being affected. Because it's a vasodilator, some of the contraindications specifically relate to hypotension. So if the patient's systolic blood pressure is less than 90, that would be a contraindication because it will drop the patient's blood pressure. Any taking of Viagra within the last 24 hours or Cialis within the last 48, those two medications act synergistically with each other, so they drastically decrease the blood pressure. dose is going to be 0.4 milligrams. It comes in a specialized vial like this. The reason why it's brown is because the nitro actually does react to light. Make sure that if you are administering or assisting administration of nitro, that you put the nitro tablets into a gloved hand, not your bare hand, because your skin will absorb that medication. Now we can give it up to 3 times, very similar to our albuterol, and then we're going to reassess the severity of the pain level and then also reassess blood pressure. Epinephrine, we're going to give this for anaphylactic reaction. The contraindications are going to be none in the emergency setting. Our dose is going to be 0.3 milligrams for our adult patient, 0.15 milligrams for our pediatric patient. Couple of different forms that it comes in. We carry the vials, which is a 1-to-1 solution, and then given either intramuscular or subcutaneous. The EpiPen itself will give it intramuscular, and then the new auto injectors that actually talks to you will give the same dose, and then it's the same thing where it's given intramuscular into the side of the thigh. Narcan, utilized for opioid-based overdoses. So our signs and symptoms are going to include those pinpoint pupils, drug paraphernalia on scene, altered level of consciousness, and a diminished respiratory drive. Only contraindications out there are a known hypersensitivity. So this is a very small percentage of the population where there has been some pretty severe adverse effects of Narcan, specifically leading to a cardiac dysrhythmia. Our dose, 0.4 milligrams, titrate to effect. It is a 1-to-1 solution. So if I want to give 0.4 milligrams, I get giving 0.4 cc's of fluid. Make sure that we push that fast so it atomizes, because if we push it slow, it's still in liquid form and it's more difficult to actually uptake. Glucagon, utilized for hypoglycemic patients in the event that we cannot utilize oral glucose because they have an altered mental status or are unresponsive. So it's going to introduce sugar into the system similar to our glucose, only in a different simple sugar complex. The only contraindication is a known hypersensitivity or known hyperglycemia. It's going to be 1 gram of glucagon. How that's given is going to be subcutaneously. The glucagon itself is going to come in a powder form inside the vial. Your needle is going to have saline in it. You're going to go ahead, put your saline in the vial, swish that around until it becomes a compound, draw it back up, and then you can go ahead and administer. Now, glucagon is also losing favor, and it's based on a cost effectiveness. So this kit, it's got a plastic box, a vial of glucagon, which is a hormone that they extract from pigs, a syringe with some normal saline in it, is currently selling for $750 on Boundtree. So with drug names, we have 3 different types. We have chemical name, we have the generic name, and then we have the trade name. So your chemical name is going to be the specific chemical compound associated with it. Your generic name is going to be your aspirin, and then the specific brand name is going to be from the manufacturer that actually produces that. So with routes of administration, each route is going to have a different onset of effects. So for EMTs, we can give sublingual, oral, inhalation, intramuscular, and subcutaneous. When the medics arrive, they can give also IV and IO. So IV medications, IO medications, generally our desired effect is going to be displayed within about 30 seconds. For us, when we're given medications, the fastest medication that's going to be absolved is going to be inhalation, which usually takes about a minute or 2. Then intranasal, and the intranasal takes right around 3 to 5 minutes. Sublingual, followed by oral, and then last intramuscular and subcutaneous. Now, as far as how fast that they react with the body also has to do with the perfusion of the body, and then also specifically the medication. So when we're looking at intramuscular, which usually takes right around 30 minutes as far as desired effects, when we administer epinephrine, because it's a high concentration of 1 to 1,000, we see the desired effects almost immediately. Now, other medications are going to take quite a bit longer as far as seeing those desired routes. So prior to giving medication, remember the basic rule of EMS, and that is primum non nocere, which means first do no harm. So before we give that medication, make sure that we're going through this. Am I meeting all of the indications? Am I meeting all of the contraindications? What's my desired dose? How am I going to administer this? What is the mechanism of actions? What potential side effects can I see? And then, of course, proper reassessment of that patient. So for documentation purposes, make sure that we are doing the 5 rights when we are documenting. So we had the right patient, they were displaying the right indications, and they did not meet the contraindication status. We had the right medication with the right mechanism of action based on that patient's presentation and the indications. We gave it the right route, we gave the right dose, we gave the right time. The 6th right is the right documentation, and then we reassess properly. Any questions, concerns about pharmacology? All right, thank you very much for bearing with me. I know it's been a long day. This is the last lecture, and this is medical, legal, and ethical issues. So with medical legal issues, remember we are acting as EMS providers under the guidance of our medical direction, and we need to ensure professional status in order to continue to provide that care. So we have legal duties that falls under the scope of practice that is set forth by the state. Now, the state of Wisconsin says as EMTs and an EMT service, you can provide X, Y, and Z treatments for patients presenting with X, Y, and Z symptoms. Now, then your medical director is going to be the ultimate determination as far as what specific skills that you're going to utilize within your organization. As EMS providers, we always have to provide that standard of care, and in which a competent, similarly trained EMT would act in the same given circumstance. And then, of course, we have that duty to act, which is anytime the tones go off, we have that duty to respond and treat that patient within that standard of care. Now, for protection, we have a couple of things. We have Good Samaritan law, and we also have professional liability insurance. So, because we are city employees and we are being compensated as EMS providers, we do not fall under the Good Samaritan law when we are on duty, because we are being compensated as EMS providers who are professionals. Now, let's say we get off shift, we're on our way home, we come across a motor vehicle accident, we render care to that individual, we would be then covered under the Good Samaritan law, because at that specific time, I am not being compensated as an EMS provider. However, we have to act in good faith, and we still have to provide that continuation and quality care as a normal EMT would do in a same circumstance. So looking at the different types of consent, first we have informed consent. So prior to actually administering a medication or intervention, what we should do is relay, this is what it's going to do to your body, this is how it's going to help your signs and symptoms, this is the specific route that I'm going to give, and then that patient is going to go ahead and say, yes, you can provide that treatment for me. Next, with express consent, so when we approach our patient after they have called 911 or somebody has called 911 for us, and then we introduce ourselves and build that patient rapport, we're going to get that express consent from that patient saying, yes, you can go ahead and help me. Now, in the event we arrive on scene, patient's unresponsive or has an altered mental status, that relationship is going to be implied consent. And in which case, if this individual was actually alert and oriented and responsive, they would go ahead and say, yes, you can render care to me. Minor consent, so under the age of 18, we recognize these individuals as not having the ability to accept and or refuse medical care. So this has to be done by a parent and or a legal guardian. In the event that we cannot reach the parent or legal guardian, it would fall under implied consent. That if the parent or legal guardian could have been contacted, they would go ahead and say, yes, you can treat my son and or daughter. And then there's involuntary consent. So involuntary consent has got to be made by law enforcement in order to get the documentation channels properly there, because we cannot take an individual and treat them or transport them against their wishes unless we have that further legal liability that is the law enforcement. So with negligence, so negligence is the unknowing poor actions that is EMS providers. So this is different than an intentional tort, in which an intentional tort is I knowingly am doing something to harm that patient. So with negligence, we need a couple of things in order to prove that. We need a duty to act, we breach that duty, there were damages based on my actions or my misactions, and then there was proximate cause between those three. So now we're going to go through a couple of different scenarios that's really going to highlight some legal, ethical, and medical aspects. So we're dispatched to a nursing home. We have an 87-year-old male patient who began choking on a piece of steak at dinner. Patient's unresponsive, not breathing, unknown pulse. Under protocols from the nursing home, they are not able to touch the patient or provide CPR at this time. We arrive on scene, patient has a valid DNR, and that DNR is present upon our arrival. So with DNRs, we should honor them in any way, shape, or form. Remember, most DNRs in that language will specify that you can treat reversible causes. And when they say reversible causes, specifically, they are referring to choking. So if I arrive on scene, that patient still has a pulse, they're not breathing, they're unresponsive, I can perform chest compressions on this individual, utilize my Bengill forceps and my laryngoscope to try and dislodge that object. If I arrive on scene, the patient's already in cardiac arrest, so they do not have a pulse, you have to err on the side of caution. Are you going to perform CPR on them, even though that they have valid DNR, knowing that this was a reversible cause, or are you going to honor that DNR? Because it's a reversible cause, I would always err on the side of caution and start performing CPR, and then make sure that you contact medical direction as soon as you can to try and get orders to discontinue. You're dispatched, 89-year-old male patient not breathing. Upon scene arrival, patient is noted as not breathing, no pulse. Patient's wife states that she has a DNR somewhere in the house. Unable to find it at this time, asks you to leave her husband in peace. You grant her request, ask for law enforcement, and clear. So, as mentioned in the previous scenario, you need to have that DNR present in order to honor it. So if family members have it stored away in the house, safety deposit box, it is not valid until we actually have it in hand. So in this case, we could actually be found negligent because we breached our duty to act. There was damages because the patient actually died, and then there was proximate cause between all of those different categories. So remember, state statutes directly affect how the states honor DNRs. State of Wisconsin honors DNR bracelets. The state of Minnesota does not. Minnesota is strictly paper. Wisconsin is both bracelets and paper. Come across a patient who's got a do not resuscitate tattoo on the center of their chest. I do not know of any state that actually honors the tattoo. Now, as far as voiding DNRs, I believe, and I haven't looked up the state statute in Wisconsin in about a year, but I believe the patient is the only one who can actually void that DNR. So if I arrive on scene and the patient's swirling the drain, but they're still competent, and patient looks at me and says, please perform resuscitative efforts on me in the event that I go into cardiac arrest, then that DNR would be voided. Make sure that you're performing good quality documentation after that call. Some states will actually honor family members to void that DNR. There's not a lot of states out there that actually allow that. You're dispatched, Holly gas station, 16-year-old female patient taking a bunch of pills. 911 call was made by her boyfriend. Upon scene arrival, patient denies taking any pills at all. Boyfriend didn't actually witness her take any, but is concerned. She does take Ativan. Ativan pill bottle is missing. Parents cannot be reached. Well, this is relatively simple because we have a patient who's under the age of 18, can't reach the parents. This is going to be implied consent, and then we're going to go ahead and treat our patient. Where we run into the gray area is what happens if this patient is actually 18 or older? Does she have the right to refuse? And the answer is yes, because a patient who is alert and oriented and vitally stable does have that right, unless they do admit to suicidal ideation in which they attempted to harm themselves and or harmed others. So if we can't prove that the patient is at a threat to themselves or others, what we have to do is properly inform them of what their actions could cause as far as repercussions. So, ma'am, you know, if you did take a bunch of Ativan, what it's going to do is it's going to be a central nervous system depressant, and in which you're going to stop breathing, your heart's going to stop, and then you are going to die if you don't get medical attention. So using the words dead, dying, die, something along those lines at the end of your little spiel is going to better protect yourself, and then make sure that you are documenting that in its entirety. Your dispatch, 56-year-old female patient, difficulty breathing. Upon scene arrival, you find the patient sitting in a chair with some shortness of breath. Patient is a frequent flyer, transported to the hospital yesterday. You decide that the patient doesn't need to go to the hospital and tell her that. Patient still requests to be transported. It's at the end of your shift, your give a damn is busted, and you clear with a patient no need. So this is a classic example of patient abandonment, in which we have that duty to act with this patient calling 911, which established that duty, and then we breach that duty as far as providing transport and treatment. State of Wisconsin, state of Minnesota says that if somebody wants to go to the hospital and they activated 911, we have to bring them to the hospital. Now, other states are starting to change those guidelines, specifically Florida, California. They are actually giving the power to some of the paramedics that if they arrive on scene and deem it a non-life threat, or they could receive treatment from simply staying at home, following up with their primary physician, they can deny transport. But at this time in Wisconsin, we cannot do that. If they call, we have to provide transport. Now, other things as far as abandonment goes is when we are handing off that patient, we have to provide that with a equal or higher level of care depending on the interventions. Now, with the interventions, I could technically hand off my patient to an EMR level if there are no EMT level skills or interventions that are being performed on that patient. You are dispatched for a cardiac arrest. You are 1 week away from getting your paramedic certification. Paramedics on scene are having difficulty intubating and ask you to intubate the patient. You successfully intubate, receive ROSC, and transport the patient. ROSC is a return of spontaneous circulation. So remember, we have to act within scope of practice determined by the state. We also have to act within the specific medical guidelines that is set forth by our medical director and by our organization. So in this specific circumstance, not only if we were on Superior Fire Department at this point, we broke our medical guidelines, we broke the scope of practice, and then we acted outside of our licensure level. So even, let's say we do have a paramedic license and we perform an ALS level skill that's out of our medical guidelines, we could also get in trouble, which I have never done when I was working at Superior. So that's good. You were dispatched for a female abdominal pain. You go through an intersection going at about 55 miles an hour, collide with another vehicle, driver is dead upon assessment. Remember, we have to drive with what's called due regard. So we are allowed some measures as far as exceeding the speed limit, but when it comes to red lights and stop signs, we should come to a complete stop and ensure that we are getting waved across by the individuals that are inside that intersection. You are dispatched for a 6-year-old male patient who fell down a flight of stairs. Upon scene arrival, you find that patient sitting on the couch, head in his hands. Patient's not answering any questions, but just continues to say, "I'm sorry." Patient has multiple bruises on his body that are both new and old. Patient's father is on scene, very standoffish, not giving a great deal of information, besides that the boy fell down and is very clumsy. So with this, remember, we are patient advocates and we are mandatory reporters. So mandatory reporters, we need to provide documentation as far as any suspected child abuse, domestic abuse, and or elderly abuse. Now, with this scenario, a bunch of red flags are going up because this individual's got new and old bruises on his face. You know, kids fall down, they hurt themselves. The bruises tend to be on the arms and on the legs. So if we're seeing it on the face, that is a big red flag. Not to mention old and new bruises. Remember, new bruises are going to be dark black, purple, blue. Old bruises, once they start to heal, are going to be yellow, green. Now, as far as doing a good patient assessment, it's going to be very difficult to get the proper information from this patient when the family members are there, or excuse me, the father is on scene. So make sure that we got law enforcement going right away. Try and separate the two if we can so that we can do a good patient assessment. Luckily, most dispatch information when it does involve a pediatric is automatically going to send a law enforcement officer as well. You're dispatched for a 68-year-old male patient who cannot care for themselves. Call was made by a family member. Upon scene arrival, you find a patient in poor but livable conditions. Patient has cancer, DNR, and is on hospice care. Patient does not have any complaints but is weak and has an increased level of breathing at this time. You deem it necessary for the patient to go to the hospital, force him onto the stretcher, and take him in, even though he is alert and oriented and is able to make his own medical decisions at this time. So what this is it's kidnapping, and it can also be considered assault and battery. So every patient has the right to refuse as long as that they are alert and oriented. We as EMS providers cannot force anybody to actually go to the hospital. That is law enforcement's job as far as putting individuals on hold, and then also trying to get medical direction involved so that the medical direction, as far as doctors go, can make the determination that yes, this patient's displaying X, Y, and Z signs and symptoms. They need to be seen in the hospital. And as a result, we can get law enforcement, give them that information so that we can make the best decision for the patient. You are dispatched for a one-vehicle motor accident with airbag deployment. Upon scene arrival, you find a 16-year-old female patient with a head laceration, no other injuries. Her 9-month-old daughter is in a car seat in the back of the car with no apparent injuries. 16-year-old female is complaining of some head pain, probably needs a couple of stitches. Her daughter in the back seat has no apparent injuries at all. The 16-year-old female is trying to refuse care for herself and for her daughter. So can she do this? First off, can she refuse care for her daughter? And the answer is yes. She is the primary parent and guardian, but can she actually refuse care for herself being under the age of 18? Now, I have not looked at this statute in a while, but in the state of Wisconsin, the last time I checked, an individual who has given birth or who is currently pregnant actually is deemed an adult in the eyes of the state of Wisconsin. So because this patient has given birth and is caring for her child, she has the right to refuse medical care and treatment for herself and for her daughter. Now, every state is going to look at this a little bit differently. Some states will require that even though you're pregnant or have given birth, you still go through the steps as far as being emancipated, which is a court proceeding where the court will determine that, yes, you are an adult at this point. Other states simply say if they're pregnant or who have given birth, then they're going to be considered an adult at this time. Where we run into emancipation most often is in cases like this, where an individual is taking care of a child, they go to court, they get declared an adult, and or if we have a single family house or a single parent household, the son or daughter is the primary means of providing care. So if you have a single family household, mom's got cancer, she has a son who's 17 years old, he is the primary means of necessities, they can go to court and then get that emancipation so that they can be considered an adult. You are dispatched for a female patient, suspected drug overdose. You arrive on scene, treat the patient accordingly by assisting ventilations and administering Narcan. You know the female personally, and then on social media, you go ahead and put the patient's name and the specific medical ailment that that patient was suffering from. Classic example of breakdown in HIPAA. So remember, this is privileged information as EMS providers and professionals. Do not put anything on social media. This is the #1 cause of firefighters, law enforcement officers, and EMS providers of actually losing their job because they're stupid and they put something that they're not supposed to on social media. So be very careful of what you put on there. Your dispatch for an 88-year-old female patient, possible dead on arrival. You arrive on scene, find signs of rigor mortis, modeling, and the patient is cool to the touch. You have a new member with you and decide to work the cardiac arrest for practice for your new member. Mayo arrives on scene, assists in cardiac arrest efforts, contacts medical control, and terminates resuscitative efforts. So what you did here is you did not act in good faith or as a good, prudent EMT. And then as far as ethical responsibilities, because we actually worked that cardiac arrest and Mayo provided treatment, that family member or that family is actually going to get a bill for services rendered. So leave the dead in peace. If you are in doubt at all whether you should work that cardiac arrest or not, go ahead and work that cardiac arrest. Last one. Your dispatch for a 54-year-old male patient experiencing chest pain. You respond to the scene, treat your patient. 2 months ago, your NREMT certification and your EMSRB license expired. You failed to renew both cert and license. So at this point, what you did is you have been acting as an EMS provider without your license. Remember, your license is your right to actually treat, and that has to be done under medical direction by being affiliated with a specific emergency medical service, such as the City of Superior Fire Department, working under Dr. Zadi's license. Now, don't forget, there is a difference between certification and license. So your NREMT certification, when you renew that, you are giving evidence stating that you have met all of the requirements by education and training to continue and renew your certification. In order to practice, you also need to renew your license. So just because you renewed your NREMT doesn't mean that your state of Wisconsin license automatically renews. You have to renew that license as well. The state of Wisconsin does not require EMS providers to uphold their national registry. However, there is always a chance that they may force individuals to do so. So if you do have your national registry, I highly recommend that you uphold that. It's relatively easy. And then, of course, make sure that your license is good to go. State of Wisconsin, this last go round, has actually changed their license requirements to once every 2 years and changed that to once every 3 years. National registry is still once every 2 years. American Heart Association certifications are still once every 2 years. And that does it. Does anybody have any questions, concerns about anything that I covered today?
So we're thinking at North 19th and Banks. Corey, can you hear us now? Corey?
Yeah, I can't hear you. What are you saying?
All right, hold on a sec. We're just trying to get the mic set up.
All right, I can hear you now.
Okay. No questions from headquarters. Thank you.
All right. Well, thanks, guys.
Who's out on a med right now, so they won't have any, and I don't know about infantry. I don't know. Can you unmute them to see if they do?
They have to unmute themselves. They don't look like they're stirring around too fast. So,
their screen's froze up, I think.
last thing is, yeah, no problem. The last thing is your homework assignment for the evening. What I want you guys to do is to watch the movie One Flew Over the Cuckoo's Nest. The movie is on Netflix, and it paints a really good picture of some different psychiatric conditions that I cannot relay adequately to you. So go ahead and watch that movie tonight with your crew, and then get some of that information from there. Other than that, we are done.
Thanks.